Hello, everyone.
Hello everyone. Welcome everyone to the second day of the Global Health International Congress. It's a pleasure to have you all with us. Our day is full of interesting lectures, and I hope you all enjoy this conference as much as I do. And remember, send your questions to the speakers via chat. So, to start our day, I would like to invite the mediators and supporting team, Andressa Nascimento, medical student at UniBH, Brazil, and Edson Silveira, international analyst. To start our lectures, I will now invite Amin Alaspa. Amin is a fifth-year medical student from Syria, studying at Near East University at the Turkish Republic of Northern Cyprus. Currently, he is the National Officer of Human Rights and Peace at the Medical Students Association of Northern Cyprus. Welcome, Amin. It's a pleasure to have you here today.
Thank you very much, and thank you for the nice invitation. And so pleasure to be here in this great conference. Shall we start now?
Yes, please.
Hello, everyone. I'm Amin, and today I'm going to talk about the consequences of conflicts. First, we're going to start with the definition. Conflict can be defined as a social phenomenon that includes a state of psychological pressure or uneasiness resulting from the disagreement between two or more desires, wills, or opinions. Conflict can be an internal in the same person or external between two or more people. And examples of that, relationship conflict, ethnic conflict, religious conflicts. Today, I'm going to focus about peaceful conflict and violent conflict. Peaceful conflict, when conflicting interests and demands are realized using codified and disciplined mechanisms, the conflict becomes peaceful. Among these mechanisms are constitutions and laws, family and clan formation, court systems, religious ruling, customs and tradition, dialogue and conferences. Violent conflict becomes violent when the parties give up peaceful means and try to control or destroy the capabilities of the violator in order to achieve their goals and their own interests. I have to note that conflict and peace are not random. They are two phenomena. Their causes and what can be influenced by them can be explained. Conflict and peace are not static but dynamic and evolving with the factor of time. Not every conflict ends with violence. There are many that resolve peacefully, and preventing or stopping the emergence of violent conflict requires an understanding of the concept of peaceful and violent conflict, and an awareness of the components of peace. The concept of conflict explains many aspects of social life, such as conflict of interest, social differences, and wars between people, organizations, or groups. And from the political point of view, it refers to revolution, war, or struggles in which forces is used, such as resources of wealth, territories, money, energy, and food sources, and how these resources are distributed, power, when the dispute is over, how to divide the mechanism of government and political participation in the decision-making process. Identity is related to cultural, social, and political groups. Value, especially those represented in the system of government, religion, and ideology. This means that there is an overlap between peace and violence or war. This overlap appears in gradual terms such as flaming war, cold war, coexistence, competition, lethargy, alliance, union, and special relations. There is five intensity level to reach war: dispute, non-violent crisis, violent crisis, limited war, and war. War is an all-out conflict in which organized armed group fights. For example, what happened in Algeria and Somalia and South Sudan are now happening in Yemen, Syria, and Libya. In this chart, we can see that Eastern Mediterranean countries are one of the highest, one of the highest death rates for the ages between 10 and 19. Middle East is a hot war zone. The control of Middle East is considered a national endeavor for the major power due to the sanctities, geography, resources, and population density. For example of that, Iraq. Conflict in Iraq also reduced people's personal security and restricted their access to food, medicine, medical supplies, clean water, sanitation, shelter, and health services. People's coping capacity are already severely strained. Many will find the privation of war overwhelming and need both economic and social support. The 2003 Iraqi war, when the United States of America decided to occupy Iraq, left long-lasting effects on the healthcare system, which the Iraqi people still suffer from to this day, such as people are unable to access healthcare at least 1 month, children with diarrhea, respiratory infection, pneumonia are left untreated, insulin-dependent, diabetic were unable to receive treatment, pregnant women cannot receive antenatal care or deliver without trained assistant. Here we can see this estimation made by the United Nations Interagency Group. We can see Iraq. This estimation talking about the child mortality estimation. We can see Iraq become darker in color at 2003. That means it's increased. And next to it, Syria, which is we're gonna talk about, become darker in color, in blue color in 2012. Syria, my country. The conflict in Syria, which has been ongoing for 10 years, has destroyed the infrastructure of many disputed cities. This led to the loss of health system, food insecurity, or the spread of diseases within those areas. The absence of primary healthcare, the absence of necessary vaccinations, and environmental pollution resulting from the war contributed to the spread of these epidemics. Syrian people are trapped between two fires, the fire of war and the fire of COVID-19 crisis. And their condition says that those who didn't die in war will die of infection. Supporters of this war insist that they continue, despite the fact that the years of war have destroyed the health infrastructure. The most important diseases that the war in Syria contributed to spreading in compact effect areas are leishmania, typhoid, scabies, hepatitis C, polio. Some cases of fetal malformation were recorded. Those cases were monitored by some doctors and attributed to the use of dangerous weapons in those areas. This is also another estimation for child mortality estimation in Syria made by the UN. We can see here it start increasing, the death rates between ages 5 to 24, increasing from the end of 2011 and the spike at 2014. A study issued by the World Health Organization in 2015 on mental health and physiosocial support for Syrians affected by armed conflict stated that emotional and behavioral social problems facing the Syrian refugees are depression, frustration, anxiety, loss of control, withdrawal, aggressive behavior, difficulty interacting with others, substance abuse, grief, and fear. Physical symptoms include fatigue, sleep problems, loss of appetite, unexplained physical complaints, and stress. 1 in 5 living in an area affected by conflict is estimated to have depression and anxiety, PTSD, bipolar disorder, or schizophrenia. Because of the conflict and war, most of the healthcare centers and hospitals in conflict area have been destroyed. This prompted 2 outcomes on healthcare workers in those areas. First, rise of volunteer medical personnel who establish field hospital to support those around them, even though they lacked advanced medical equipment. Second, flee of medical personnel out of the area or country, out of the fear of arrest or killing, which played a critical role in the shortage of medical care. With a collapsed healthcare system, a battered economy, and severe lack of doctors and nurses due to medical providers fleeing Syrian portal war, authorities facing an uphill battle to control the spread of COVID-19. Chronic shortage of medical equipment and supplies, along with poor conditions at quarantine facilities, the need to earn a living, and deep distrust towards state institutions after more than 10 years of conflict. There is a huge gap between the actual number of cases and the one announced by the government due to its lack of resources and capacity to receive patients. But it also, the government needs to mitigate any unexpected impact of the COVID-19. The UN warned that community transmission was widespread as almost 90% of new cases could not be traced to unknown sources. Infection rate among health workers were rising. Hand sanitizer with a high quality mask that should be changed daily cost about 6,000 Syrian pounds, equal to $3 in the current exchanging rate, Syrian exchanging rate. Doctors cannot afford to buy a good mask with a salary short average 500,000 Syrian pound, which is around $180 per month. So how the civilian will afford that? There is also an important factor in the deterioration of the living condition of Syrians. Even in the areas that they were not destroyed, there are external factors, such as economic sanctions that led to the suspension of importing the fundamental resources required to production of simple medication, which led to the lack and loss of treatment methods. The other one is political sanctions. One of the notable negative effects on the mental health of Syrian people is during the legal traveling proceeding to other countries. Syrian passport holders are dealt in an exceptional manner, which renders them vulnerable to insult and racial discrimination. Many countries and humanitarian organizations have been providing assistance to the Syrian people affected by the war, such as building field hospital, providing medical care through volunteers, providing basic food, temporary protection, protecting and educating children. Some of these organizations are UNICEF, Doctors Without Borders, the White Helmet, the International Committee of the Red Cross. Although these organizations provide a lot of aid, they are still not able to provide enough support due to the difficulty of delivering aid into the country due to the external sanctions on Syria. In conclusion, wars cause an enormous amount of death and disability worldwide. It destroys family, communities, and cultures. It diverts scarce resources. It disrupts the societal infrastructure that support health. It forces people to leave their homes and become internally displaced person between cities, or refugees who have fled to other countries like Lebanon, Jordan, Turkey, Iraq. It violates human rights. Conflict of all kinds, especially wars, may also be the main reason for the emergence of extremists and terrorists all over the world, which has created separatist groups that wrongly represent religions, societies, and races, which increase the hatred between people. And I would like to end up with these two sayings. According to one of the MSF logistic manager, people telling us that they are afraid from sun because plane bomb when the sky is clear. Weather forecasts say that the weather during the next days will be sunny. This one, according to one of doctors working in a hospital in Damascus. People prefer to die rather than coming to the hospital, of course, because of the bad equipment. And this is there. Thank you very much for listening and for paying attention.
Thank you very much, Amin, for the excellent presentation. It's always very important to listen to reports like yours. Thank you very much. We will ask the questions for you after the other speakers on the discussion table, okay?
Okay, thank you very much.
Thank you very much. So now, let's meet our next speaker. We now receive Dr. Mohammed Abed from Palestine. Dr. Mohammed has a master's degree in community mental health from Icahn University School of Public Health. He has worked for 13 years as program medical referent for medical programs in MSF France. Since October 2020, working as a Deputy Medical Coordinator officer for MSF France for Palestine. Welcome, Dr. Mohammed. It's a pleasure to have you here today.
Thank you very much for inviting me to the Global Health Conference to present MSF activity. Hi, Liliana, how are you? Yeah, we miss you here in Gaza. Yeah. So I'm very happy to present MSF activities in a conflict zone. And when you speak about conflict, it is, I mean, Palestine and Gaza, West Bank. I'm very happy to see some people that I know here who were actually in the mission of Palestine. Dr. Eliana, who was present during the emergency time for 3 times in Gaza, which she did a very great job for the patients of Palestine. So I will share my presentation. Okay. Sorry, okay. So I will speak about the medical care in Palestine, and as I said before, it's it's a conflict zone since many years, and I will start with this footage. One of our MSF patients that was injured during the Great March of Return. We will speak later about this issue in the coming slides. MSF in Palestine is working since 2000 in the occupied Palestinian territories, in West Bank and in Gaza. MSF has been working, providing medical and mental health care to respond to the direct and indirect consequences of violence in this area. Who knows? I mean, just to show you the map of the occupied territories. This is West Bank and Gaza. The small region in green is Gaza Strip, and the little bit big one is West Bank. Here is more showing more the West Bank. Of course, there is a wall around the West Bank, and Gaza, which is the small green one here, which is a very small region. The West Bank and Gaza has been under the Israeli military occupation for over 50 years. In Gaza, there is a blockade since 2007, which resulted in severe limitation of movement for around 2 million people, while restriction on entry as well for goods, which had devastating the effect on the Gaza economy. In the West Bank, there is 3 million Palestinians living in scattered areas because of the war, which is separating the region of West Bank to some areas. They call it A, B, C, and this is according to the Israeli restriction on the movement, related to the movement, with a lot of checkpoints and, of course, limitation of movement of people. In Gaza, the West Bank, in Gaza, sorry, the blockade is, as I said, it's since 13 years, since 2007. It's by land, sea, and air. So it's a small jail. It's 365 kilometers square with 2 million population. Imagine. The unemployment rate is 47%, and 80% of the population, they depend on humanitarian aid. There is different difficulties in the both regions. The chronic shortage of drugs and disposables, mainly in Gaza, which is around 52% of the essential drugs are zero, and 56% of the essential medical disposable zero. This is a chronic issue since the blockade. The electricity situation is fluctuating in Gaza. Sometimes there is cut from 12 to 20 hours cut. And this happened after bombing in 2008 to the power plant. The medical staff who are working in the health facilities here, they receive 40% of their salaries, and sometimes every 40 to 50 days they receive this 40% of their total salaries. So imagine the motivation that they have. The permits to cross the medical care in Israeli hospital is still very low. Majority of the patients who need specialized treatment in Israel, they are rejected. There is importation of supplies and equipment as well as a major challenge. So if there is a medical equipment that needs spare parts, you cannot import it into Gaza or sometimes West Bank. As we mentioned, there is a high unemployment rate, mainly among the young men or youngs, and there is no job, and it means that there is no future. Recent survey revealed that 80% of the youth would leave if they had the opportunity from Gaza, and this is already started. They are speaking about 30,000 young men left Gaza in the last 3 years. UNRWA is the UN which provide medical and educational care for the refugees, which represent 60% of the population. They have lack of funds most of the time, and now they are as well facing lack of funds after the cut of funds from the USA. Conflict to last, so there is no solution. The borders are semi-closed most of the time. I mean Israeli borders and the Egyptian borders. So most of the time they are closed. So there is no positive changes, sorry. I'll start with the activities of MSF in the West Bank. So here, as you see, this is the wall that separates West Bank cities and villages. This wall is dividing it into sectors and the fragmentation of the West Bank. Sometimes you have your house between is divided, or your land is divided by this wall. I think the same wall was built as well in between United States and Mexico. In West Bank, MSF is providing mental health care for moderate and severe mental health illnesses. This include psychotherapy, clinical short-term psychotherapy, building capacity, psychiatric care, and community awareness. This is done by a mixed clinical psychologists, foreigners, expat, and national team. It's a multidisciplinary team which consists of psychologists, psychiatrists, social workers, and community workers. This is some of the group therapy that is done for the population there through MSF counselors. And it could be a counselor with a translator if the counselor is, if the psychologist or the counselor are foreigner. So we have a translator which works together. This is as well some psychotherapy for children done by MSF psychologist. So she's a foreigner and she has the translator with her. MSF is working really with the community to raise awareness about the stigma and the need of mental health support, which in the Middle East, it's a big challenge as well in other countries regarding the services of mental health. Here I want just to show that the type of mental health illnesses that we see in our patients, the children or adults. Majority, they are complaining of anxiety, children behavior, trauma-related things, depression, family problems. In adults, moderate depression, severe depression, PTSD, chronic anxiety, risk behavior. All of this related to the ongoing conflict in West Bank. Gaza activities, we have different activities in Gaza. This is one of our clinics in Gaza City, which provide post-operative care for trauma and burn patients. And this photo was taken during the Great March. As you see, most of them are trauma patients with lower extremity injuries. As I said, MSF provides medical, surgical, and psychosocial support for burn and trauma patients. We have 4 clinics in Gaza, which provide physiotherapy, occupational therapy, dressing care, pain management, health education, and psychosocial support. There is 2 surgical as well teams, an orthopedic surgical team providing surgical for the trauma patient, and a plastic team which provide care for the acute and semi-acute burn patients. We have an osteomyelitis as well unit with 22 bed capacity. And we have a specialized microbiology lab and a stewardship team, which was related to the type of injuries that we had during the Great March. And finally, the COVID intervention, MSF is involved as well in the support of the hospitals here in case management, oxygen therapy with the Ministry of Health in the COVID intervention. As may you heard, Gaza had faced 3 wars during the last decade, and recently in 2018, one of the major demonstrations in the region that happened in Gaza, which was called the Great March of Return. It's mainly young men who were really going to the borders to protest against the occupation. During this demonstration, which was held every Friday and since March 2018, there were more than 30,000 people who were injured. 60% of them, they needed hospital treatment. I mean here that they had live bullets, gunshot injuries. So there was around 6,800 patients with live bullet injuries during these demonstrations, which stayed for 1 year. This is the type of demonstration, mainly young men, children, women, mixed. All of them, they go on Friday to demonstrate near the borders. So this is photos from the demonstrations, and all these. I mean, as you can see, it's mixed between women, children, and even people who were injured during the war. They were participating, like the guy on the wheelchair. He was injured during the war. He lost his both lower extremities, but still he was coming for demonstrations. MSF managed to, to integrate 49% of all these gunshot injuries in their clinics, to provide for them dressing, physiotherapy, and surgical intervention, because these patients were coming to the hospitals, were admitted in the emergency, they were operated, the first operation, and they were discharged very early to be able to keep the hospitals empty for the next Friday. So they were really emptying the hospital to keep the beds empty for another wave of injuries of next Friday. So patients were coming with fresh wounds, discharged with fresh wounds, big wounds, as I will come show you. What we were seeing, we are not expert in bullets, or we are not military experts, but what we saw in the patients who were arriving to the MSF clinics, they have excess wounds with large size. The entrance were small. There was massive laceration in the tissues and the muscles and bones. As you know, we have to remember that bullets are not sterilized, and bullets can be. So this is exactly what we were receiving from the hospitals in the OPD clinics in order to receive dressing for these types of wounds. This is some X-rays of the type of wounds that we were receiving. So, and to do all of this, MSF, it's a huge job with the number of patients that we were receiving. MSF planned to increase their capacity in Gaza in terms of the medical activity. So from 3 clinics, we increased to 5 clinics. At the beginning, we increased from 1 surgical team to 2 surgical team. The national and international staff from 80 people to 250 people to be able to cope with these patients. This is in the waiting area and outside the clinic. So it was like a museum of lower extremity injuries with external fixators. These patients, the treatment of these patients need several services. And they needed a dedicated ward beds. operating, surgical capacity, multidisciplinary team of orthopedic, plastic, physiotherapists, nurses, mental health, psychosocial support, in addition to a clear protocol to use the antibiotic team with microbiology lab. This type of these patients, they will need 2 to 3 years with several surgeries of correction, reconstructive surgery, plus the treatment of the infection of the bone, which is called osteomyelitis. We have an approach called patient-centered approach now in our activities in Gaza, which everyone is involved, a multidisciplinary approach, which include every aspect, the pain management, the psychosocial, the education, the nursing care, the surgical, and the reconstructive, and the treatment of osteomyelitis. And here I want to say that thanks to Dr. Raquel, who started the osteomyelitis program, our stewardship activity in Gaza, Dr. Raquel from Brazil. And she started this activity in 2018 when we started to treat these infected patients. 80%, 86% of bone biopsies which we are taking from these patients have been positive to infection, and out of the 80%, 61% of these patients have multi-resistant to antibiotic, which is a regional problem in the Middle East. This is our mixed team between counselor, physiotherapist, nursing care, educational, with a patient that's operated in our facility he had an amputation, and this shows that the multidisciplinary approach or the patient-centered approach. So the journey is so long with these patients. It's a long journey. A majority of these patients, as I mentioned, bones, and the infection of the bone, the osteomyelitis, takes long time for treatment, plus the reconstructive phase, which could be 2 to 3 surgeries in the coming 2 to 3 years. And finally, we are part of this world in fighting this pandemic in Palestine, in West Bank and Gaza, and with the limited resources and limited capacity of ICU. In Gaza, mainly the situation was controlled because Gaza is closed, but unfortunately in August, we had an outbreak in the community, and now we have increased number of positive cases, active positive cases now in Gaza. The hospitals are almost full. The ICU capacity is almost full. We have teams working inside the ICU, a doctor and a nurse from expat who came from different countries. They are supporting the Ministry of Health hospitals here. We did a huge donation to the hospitals for some PPE material and oxygen material to support the Gaza situation now in COVID. So thank you so much. I want just to show you one of our patients who was in the first slide using his crutches to play music.
Dr. Mohammed, is it well?
Sorry. Yes.
Yes.
Tamam. Okay.
I think you have to stop the share screen and share again with some.
Okay.
It's still not working.
Not working, yeah?
Yeah.
So,
Okay. No, that's what I want to show. This patient is one of MSF patients who were injured during the Great March. He was referred to our facility in Amman in Jordan. They have a reconstructive hospital. He was operated in Amman there. And of course, after difficulties of getting him out of Gaza because of, as I told, the restriction of movement for toward Israel or Egypt. But finally, after 6 months, we managed to transfer him to MSF hospital in Amman, and he got his surgery there and treatment. Still, he needs several surgeries. Unfortunately, now we cannot send him back to Amman for the follow-up. We are trying here with in Gaza through the MSF to do the surgery here for him. Thank you very much.
Thank you very much, Dr. Mohammed. Thank you for this amazing talk, and I look forward to learning more from you during the discussion. Thank you very much.
Okay.
I will turn the floor over to you, Andressa.
Okay, hey, good afternoon, people. Everybody's listening me? Okay, at least here in Brazil, it's almost 2 o'clock, so in the afternoon. As I know, we have people from all of the world here today. Send us, please, in the comments, where are you from and what time's out there? It will be so cool to get just a sense of the incredible global reach of this Congress. So my name is Andressa, and I'm going to lead the next lecture now. And I present to you the third speaker of the day, and will be Dr. Liliana Mesquita. Dr. Liliana Mesquita is a medical residency and anesthesiologist at ABDF and postgraduate student of anesthesia and pediatric intensive care at Sírio-Libanês, São Paulo. Anesthesiologist at ABDF and at the Children's Hospitals of Brasilia and the international organization Doctors Without Borders. 12 humanitarian missions. Okay, it's a lot of missions, so I'm so curious for your speak today. So welcome, Dr. Liliana. It's a pleasure to have you here today, and now it's your time.
So thank you for the invitation. I'm very happy and more happy when I saw that Abu Abed Mohammed, because we call him in Gaza as Abu Abed. So I'm very, very happy because Abu Abed does a very, very good job in Gaza. I was there 3 times, and since the first time, 2012, I met him. So he's a good friend, and give a big hug to all the team there in Gaza. So let's start. Okay, can I start? Shall we? So how they say, my name is Liliana Mesquita. I'm a medical doctor, anesthesiologist, and I started my job with Doctors Without Borders in 2010. And my lecture will be Médecins Sans Frontières, my experience after 12 missions. So I always like to say that work with MSF is like go from the comfort zone to the conflict zone, because it's very, very hard to be there. And as an anesthesiologist, normally MSF send me to conflict zones and the trauma center as well. So only to give you a brief, Médecins Sans Frontières, or Doctors Without Borders, is an international independent medical humanitarian organization, and it was created in 1971 after Biafra War in Nigeria by doctors and journalists and in Paris. So our goal is not only to provide medical assistance to people affected by conflicts, epidemics, disaster, or exclusion from healthcare, but also to share with you what we can see in the field, because a lot of things is very hard to see, and normally is not shown in the media, in the newspapers as well. So, and in 1999, we received the Nobel Peace Prize. So this is my 12 humanitarian missions. So I'd like to say that you have to think that humanitarian missions is a part of a humanitarian response. So we have to, in difficult places, we have a lot of kinds of jobs. So the humanitarian missions is a part of the humanitarian response. When you have a refugee crisis, internal displacement, you can see in the conflict zone, yes. So, also our goal is to fundraising and to show what we see in the field, and looking for more people to go to the field and to fundraise in the organization. So this is the place. When I started 2010, I was in Haiti and Pakistan and in Central African Republic. And 2011, I was in Sudan and Pakistan. 2012, 2014, and 2018, I was in Palestine, Gaza Strip. How Abu Abed said, in the last decade, Gaza has 3 wars, and I was there in two of them. Because when I was in 2012, I received a lot of patients from the war in 2009. In 2013, I was in Yemen, and 2016, 2019, I was in Afghanistan. And in 2017, I was in Iraq. So this is the hospital. I was in Mosul, Iraq. This is the big hospital there. It was the first time I had the opportunity to help to build the hospital. So you can say here is the entrance. And I think that you remember that Mosul in 2017, we have the Daesh, Islamic State, we can call Daesh or Islamic State, was in Mosul. So we were here in Mosul, and this is the hospital. And I have the first opportunity I have to see the hospital is building from the first steps. So this is the entrance. You have so many tents. It was in March and April, so a lot of, it's very cold there in this time. So here we have the emergency room, and here the OT room, OT. This is the toilets, the morgue, the water, the female and the male ward. And here we have another tent. I will show you another tent of the surgical OT. So this is the operation room. And this is here inside in the container. This is a prototype. The first time you have to use the container. So they call this container, we call this MUST, M-U-S-T. So it's a mobile unit surgical trailer. It was the first time. It's very, very impressive, because we can start, when you put this in the truck, we can start any operation before 3 hours. And this one here is like we have in Gaza. And here we have the tent. So we spend more time to building this tent than this one here. So this is very, very quickly to start any surgery here. Well, this is another tent. This is the emergency room. So as anesthesiologist, we can go also to the ER, the emergency room, because we in France, we call us as resuscitation. We are anesthetist and resuscitation. Anesthésiste ou réanimateur en français. So I mean, here is the only place that we have warm, because you know when we receive the patients, we have to let the patient naked to see the injuries, the burn. So this is the only tent that we have warm. Because of this, I'm here with the long sleeves and legs, because it's very, very cold this time there. Here is not cold because we have a heater, but the other place we don't have, so it's very, very cold. So here we have the emergency room, and here is when the patient arrive here, and here we put the patients more with more injuries. So, and here we have a dash monitor, we have ambu bag, we have an oxygen concentrator, and here we can stabilize the patients, and after send him to the container I showed you before, the MUST. Or if you have already a surgery in there, we can put the next patient in the tent. So this is the anesthesia team. This is me. This is a real picture. I never saw before. I never know before they are taking pictures of me. And here is the Australian anesthesiologist. He had this time 71 years old. And you know that as I talked to you before, the anesthesia team, we can go to the ER and the OR, the operative room. So this is a child we received from the Mosul in the city because of the war. So we received the patient, we can stabilize it, put the IV line here, gave the patient's fluids. This child arriving here in the emergency room with ketamine. So he stayed a lot of unconsciousness, but he's stable after this. Well, this is very hard to me. The operation room, I received this boy without any identification, only with number 3. You see here the number 3 on the cheek. He did a laparotomy because of the war. And this is, for me, is very hard because Abu Abed know I play a lot with the children. I'm a pediatric anesthesiologist, so I like to know the name of the child. I'd like to talk to the parents. I talk with the family. And for me to receive a child like this, because you know that in war, the most fragile part of the war is the child. And for me, it's very, very broken heart. Well, this is another problem, how I told you. This is the emergency room, and I was there with this young girl without any identification, and neither her parents. She had a closed fracture here in the left leg, and she arrived with a lot of clothes, and so we had to take out all the clothes of her and to see and looking for the injuries, but she was good, more or less, but we can stabilize her. And here we have the dressing, and but we didn't find her mother, her parents, siblings, brothers and sisters. So she stayed with me in my arm for a long time. And when I receive in the more child with the emergency room, I have to see all these children with her in my arms, because when I put her in the chair or give her to another colleague from MSF, she starts to cry. So I stay with her for a long time until we find until her, I think his aunt arrived in the MSF compound and said that that she was her aunt. So here we have more children. As I told you, the most fragile part of the war is child. So this is here is the surgical team. It is me, the Brazilian anesthesiologist. Here is the Swedish anesthesiologist, and here he is an Italian anesthesiologist, and another one here and here and here. They are Iraq surgeons that we work all together. And as you know, it's more difficult to find women in the surgical team. So it's very common. Abu Abed know the last time I was in Gaza, I was the only woman in the OT team. Oh, of course, we have OT nurses, but talking about surgeons and anesthesiologists, normally I am the only one woman in the surgical team. So here we have when I went to Pakistan 2010, Islamabad is the capital of Pakistan. And here it's different from Gaza. Here I have to cover my head. In Gaza, I have only to use long sleeves. Here I was with the MSF t-shirt, but it's not, I can show you this after. So I only like to tell you that in some countries you have to cover our hands, use the veil. And in Gaza, we don't need to use, but you have to use the long sleeves. So you have to respect the culture of the place. And here, Hangul is a conflict zone. It was the first time, Hangul is very special for me because it was the first time I was in a conflict zone, 2010, 10 years ago. And I became very emotional when I talk about this. This is the boy, the Brazilian anesthetist, and the Swiss surgeon. This boy, when the very hard day, we receive a lot of patients with a lot of wounds and a lot of patients we call red patients, and we had to take them to the OT to do the surgeries. And it was very hard because he was a child in this time, 10 years ago. Now he's a medical student and he wants to work with us, with Doctors Without Borders. But in this time, we arrived in the ward, in the emergency department, the emergency room, and talked to him that we know that you are a child, but we have more patients wounded, so you have to wait. So it's very difficult for me to tell this to a child because I work a lot with child. So, and he waiting almost 24 hours to go to the OT to do the surgery because he had a fracture in the leg, but not open, and he was stable. So we have more wounded patients, and we became friends on Facebook. But and another interesting thing I always said about this picture, that when I went to the ward, the male ward, because you have the female ward and the male ward, and in the male ward is only allowed to men working there. It's not allowed for women working there. So when I go to the ward, I was the only woman there. And I ask, of course, we have always to ask if we can take pictures or not. And this is one of the security rules that you have to in the field. Is very, very important to follow these rules. And I asked, can I take a picture? And the male in the ward said, no, it's not allowed for you. So I had to call the surgeon, the Swiss surgeon, to take a picture together, because I tell, oh, this is, he has the age to be my son. No, it's not allowed because you are a woman, you are a Western woman. So it's very interesting for me. And well, it's different. It's a very good experience as well. So another thing, I come back to Pakistan in 2010. Sorry, this is not 2010. This is Peshawar. Peshawar was the capital before. Peshawar is another city in Pakistan, and this picture is not 2010, 2011. Sorry. And this is the Brazilian anesthesiologist and a lot of twins. The women there didn't do the prenatal consultation, so it's not uncommon to deliver one patient, one baby, and after another baby. And we have a lot of twins there. And this is a kind of paper we can cover the babies and to protect him to lost warm. So it's important because we don't have available beds to put all of them with warm beds. So we always said that despite the war, life is renewed. And this is another very, very interesting picture and one of my favorite pictures. This is in Hangu, 2011. My mission was there in Peshawar in the maternity. It was my first time that I went to a project, only a maternity project. And they asked me if I can come back to Hangu for 1 week to cover a gap of anesthesists there. So I went to the Hangu because I was there 1 year before. And Hangu is very, very dangerous place. And it was my first time in a conflict zone. So when I was here, this patient arrived. And he has more than 100, and he was in post-op of inguinal hernia. So it's important to keep in mind that when you are in a conflict zone, the healthcare, for example, the women is still giving birth, appendectomies, hernia, cold, pneumonia. So this is still going. Okay, this is so you have to keep in mind that yes, I was in a conflict zone, but all the other illness is still going. So this patient arrived very bad, with a big inguinal hernia, and we have to put him in the operative room. And as I always said, I always like to talk to the patients, and we have the translator, because in Pakistan they don't speak English, of course, and they don't speak Arabic. They speak Urdu, is the official language of Pakistan. And I call the translator, and I take his hand, the hand of this old man, and talk to the translator to translate him. And I said, hello, my name is Liliana, I'm a Brazilian anesthesiologist. I'd like to tell you that I will take care of you, so don't be afraid, I will here beside you. And the translator told him, and in this time, he take my hands and start to say something I didn't understand, but I really understand that is a kind of saying, thank you for being here. Thank you for coming from Brazil and take care of us, our population. So it was very emotional for me, because when he started to tell this, I started crying, and he as well. I spinal anesthesia him, is very good, it's no problem. He was okay in the post-op. And this is very interesting also, because when I went to the Mayo ward, I told you before that it's not allowed for women working inside the Mayo ward, so only have men inside. And these two men here is his nephew, and this city is very close to the Afghanistan. And these two men here is from Afghanistan. They are taking care of this man. And every time I arrive close to him and to see his eyes, blah, 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 in the post-op, they turn around and stay back of me. And I didn't understand what happened. And the nurse told me, because when they say you, a Brazilian, a Western woman touching his aunt is very uncomfortable for them. So this is another, it's not a problem, but it's another, we can see these different cultures. Yes, so for me, it's a shock in the first time, but the second and the third day I arrived in the Mayo to see him in the post-op, okay, I understood. I already understood that I have to be very fast, see him in the post-op, blah, 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 and go out. So this is my first time in Gaza. I know that Abu Abed already has this picture. This in Gaza Strip, Palestine. This is the 10th hospital. And this project is very, very interesting, because it's a plastic surgery project, a reconstructive project. And we receive a lot of patients, and I receive a lot of children. So for me, it's a very, very good project. And it was my first time there. And I always says that I never thought in my mind when in the medical school that one day I go to the Midwest. So imagine come back 3 times in Gaza, Yemen, Pakistan, Afghanistan. So it's very, very emotional for me to see this again and to revive all this. So this is inside the 10th hospital. This is the same I show you in the Iraq. Here is the operation room, and here is the recovery room. And for me, it's very special, because I always said that all the tents, all the places I work with MSF, very, very good conditions. So we can see here the dash monitor. We can have here the respirator. We have here the oxygen concentrator. And so we can have the recovery room. We had the nurse, recovery nurse, to stay here with the patients after their surgery. So very, very, very organized. And I have to say congrats to Abu Abed, because he really does a very, very good job there. So this is for me, Abu Abed know Youssef, the Brazilian anesthesiologist and the lovely boy. I became very emotional when I talk about Youssef, because I was there. This is inside the tent. He arrived around 3 years old, and he has a lot of burns in his face and his hands, and he did a lot of skin grafts. So I anesthetized him a lot of times. And you know that I didn't use the scarf, you see, but the last time I was there, and he didn't speak English as well. The mother speak very, not too much English, but we had a translator. So the last time I was there, I told the translator that, tell Joseph that this is my last time here. So when he looked at me and said, Lily, I love you. So I started crying. Abu Abed know this history, became almost crying because it's touched my heart a lot. And well, I will show you another picture. So for me, it's there because when I come back there 2014, I asked Abu Abed, and Abu Abed called his mother, and he come back to the MSF office to see me. And for me, imagine, I never imagined that I would go one day to Gaza, imagine come back 2 years after, during the war, because it was very, very hard to take the decision to go to the Palestine in 2014. Abu Abed know this, it's very hard time there. And I said, no, I come back to Palestine. And I said, Abu Abed, please try to call Yosef. I'd like to see him. And Abu Abed found his mother, and he went to the MSF office with his mother. And when I saw Yosef again, I started to cry. I didn't give up. I didn't stop. I didn't get to stop crying, because for me, it's wow, it's incredible. And he a little bit shy. Remember, Abu, that he was a little bit shy because he has a lot of burns in his face. And her mother told me that when he went to the school, a lot of children and the mother of another child became a little bit afraid of him. So he thinking in his mind that he was like a monster or something like this. And when I come back in 2018, he is older. He's a boy, 10 or 11 years old. And Abu Abed called him again, and he went again to the MSF office. And this time he waiting for me in the walk outside the clinic, waiting for the MSF car. And when he look at me, he goes to me and give me a hug. So for me, this is priceless. And as I always said, that love is the international language. So it's not necessary for we to speak Urdu or English or French, but we can understand each other in the eyes and in the heart. So this is, for me, is very, very important. And I learned this with MSF. And this, as I told before, when I was in Palestine in 2014, during the war, is very hard. And I was there when the ceasefire agreement established. Do you remember, Abu Abed? We were in the, a lot of people from the MSF that working with MSF went to the office because they think that's more safe because of the bombs. So we have a lot of people in the office, and when we are waiting for the ceasefire. For me, this is, I always said that the highlights, the top 5 of my emotional things that I remember with a lot of love and a lot of affection from MSF is this time when I was in MSF office waiting for the ceasefire. Remember, yes, Abu Abed. And when the ceasefire agreement, they said, yes, we are waiting, and yes, okay, ceasefire, oh, thanks God. So everybody start to hug each other and crying because it's about their lives. So this is very, it's broken heart when you see this and all this, that family is there. This is, wow, you thinking, thanks God. So this is the Yosef. This picture it was in the Palestine 2018, and this time he is almost in my hate. He's so lovely in this time. He's not afraid, he's not shy, he's smiling. And of course, we can do more plastic surgeries him, but the function, he can open and close his hand, he can eat. So, well, if I could bring him to Brazil and ask a lot of friends, plastic surgeons I know, and say, wow, we can do more job, more things, more surgeries. But unfortunately, it's not allowed for them to leave Palestine, to leave Gaza Strip. Very, very hard. So this is another picture that for me is very, very, this picture is in 2018. I think I have already shown Abu Abed this picture. I was in a vascular surgery, how Abu Abed showed a lot of injuries in the legs. And I was there, blah, 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 the patient, and I said, I heard a cry, I can't believe, because as I already said, the life is going. So a lot of pregnant women, and the nurse told me that, you can help us because of this baby. I know that you are a pediatric anesthesiologist. So here I'm as a neonatologist, like a pediatrician, but the patient and the baby is very well, okay? I take care of the both, but it was very good. And I didn't see, but another nurse take this picture. And for me, it was amazing when I saw these pictures. It was awesome. This is when my first time in Africa, in Pauá, Central African Republic, 2010. And I always like to show this picture because when I went to the C-section of the mother of this baby, the mother didn't know yet that he's a boy or a girl. So she told us that, okay, if it will be a male, I will call him Alberto because it's the name of the Italian surgeon. And if it will be a girl, I will call Lily. So I did now, I always said that now I have a lot of collections about Lily around the world. So this is the first African Lily and the first of my collections. So when the baby born, it was a girl. So, well, here in the Hamir, another place very far from the capital of Yemen, Sana'a. And you know that 2013, we are very close to a place that, you know, Al-Qaeda is a conflict zone as well, but you know that still now you have civil war there. But as I already said, that we still have a problem, common problems that we have in any community, any city. So this girl arrived there with a burn in her face, you see here, and she has to use the scarf. And this is the clothes I have to use to go and to leave the hospital. Here inside the hospital, no problem. But when I arrive and when I leave to the hospital, I can go walking to the hospital this time. We have to use the burqa and the black burqa. It's not allowed for me to use any color burqa. And she's very shy as well and never smiling. And here in the end of my mission, I take another picture because she has injury here as well. And she's her sister. And now she's happy. I said, wow, I'm leaving and you didn't smile to me. And she smiled to me my last day there. And here, this is the first Yemeni Lily in Yemen. He is a Yemeni surgeon that we work together there. And this is the first Lily in Yemen. Again, they go to the C-section and they didn't know that it will be a girl or a boy. Well, I go walking to the hospital, and every day I go to the hospital. A lot of children go with me, and they love camera and all this. All time I pass from them, they said, camera. And I have a lot of pictures of the missions, and this is for me is very, very special because they they loved to see me, them with me, also in my last day there. Well, this is when I was in Afghanistan. Host is a city so far from the Kabul, the capital, and they call the baby factory because a lot of babies born delivery or C-section. And I was there in February 2016, and in January we had almost 2,000 babies. So a lot of babies, yes, 2,000, 2000, a lot of babies born there. And this I want to tell you that in 2015, Kunduz Trauma Center was bombed. So MSF, International MSF movement, created the hashtag Even War Has Rules here, Even War Has Rules. So because it is planned for me to go to enter to the Kunduz trauma, but in October, before 2015, Kunduz trauma was bombed. So it's very hard for all of us. And because I always think that it can be when I was there. And they changed my plans. So they sent me to Afghanistan, but to another project. And when I arrived in Coast, the baby factory, I saw this, so it's very, because all the projects around the world in MSF wrote the Even War Has Rules, the hashtag, and we did a movement. So this is the bunker. I don't know if you have you ever heard about bunker? Bunker is a place, it's a safe place that all the MSF missions we have to head in case of bombing, in case of disaster. And this is the bunker of this hospital. So you have to keep blankets, you have food, water, we have a satellite telephone, we have toilet papers. So it's difficult when I saw this for the first time, because all the projects of MSF, we need a bunker or a safety room, depends of the project. But in case, and this here is a box that we can, we put drugs, we can put IV lines, instead of someone is damaged, we can put IV lines. So when you saw this for the first time, I became a little bit scared. But after, thanks God and thanks Allah, I never had to be in the bunker. So this is the team, me, the Brazilian anesthetist, the German gynecologist, and the nurses. And as you see here, we have to use the scarf, you have to use long sleeves inside the operation room. Okay, this is inside the operation room. And this is very interesting because one day I'm walking in the compound. The compound is a place that we can have the house, the ops, and the hospital. A lot of MSF projects is like this. We live inside the compound. So one day I walking in the compound and I saw a container and I asked, what is this? Ah, this is the kindergarten. Wow, kindergarten, yes, the kindergarten inside the container. So MSF has a container that when the women that work with MSF give birth and the baby is very young and they don't have anyone to take care of the babies, we can, these women, these professionals can take the babies to the hospital and let them babies here inside the kindergarten. And MSF paid a nanny, another profession, another woman, to take care of this baby during the working hours of the mothers. So this is for me very, very interesting because it's a kind of, it's very social, it's very important for them to keep working and has some place that they can let their babies. So, and when I didn't have anything to do in the operative room, I went to the container, to the kindergarten, and take care of the baby, help the nannies there, because normally it's 1 or 2 nannies to take care of almost 10 babies. So this is not patients, this is the the babies of the workers there. And here we have also, I have also the first Afghani lily. This is the first lily in Afghanistan. So to finish is very difficult for me to speak fast because I have a lot of thousands of pictures and a lot of histories. And one of our goals is to share with you our feelings, what we feel in the field. So it's impossible for us to talk in a short time, but I tried. And I will finish with this. Deborah Noel is a psychologist that worked with MSF, and she wrote a book. And in this book, she wrote that someplace in the road, someone is waiting for you. Because normally the people ask me, why did you start the job with MSF? Maybe because of this, because someone in the place, someone is waiting for you. And this is one of our goals. The planet is our emergency room. So thank you very much. It was amazing. It's awesome to be here with you all.
Oh, thank you so much. With the global team, thank you for this incredible talk. I love so much. And now, just remember, if you have any questions, please save it for now, because we will have a QA session. And I would like to invite now Amin and Dr. Mohammed to join us to start to make some questions. So everybody who have something to ask, please send us. Amin, Mohammed, they both are here.
Yes.
Yes. Okay. So let me start the first question. The first question here is for Dr. Mohammed, and is when we think of conflicts, we usually think of physical traumas initially, but we cannot forget the psychological damage caused by the experience and this type of situation. So there is any kind of assistance for people with psychological traumas caused by conflict? If so, how is this service performed? Oh, I think Dr. Mohammed can't listen to me now. So, Dr. Liliana, did you listen? They asked for.
Yes. Well, we have.
Thank you.
I can answer because I work together with Mohammed. So yes, we have a psychologist, a mental health. I think, in Palestine we have, in West Bank we have a mental health project to the patients, and in Gaza as well. And for the professionals as well, we have a psychologist. We have before we went to the war, we have a psychologist briefing, and when we come back, because for example, when I was in Gaza this time, we were waiting for the ceasefire, and my replacement arrived in Gaza. When I start to talk to her about the surgeries and blah blah blah, and I start to cry a lot, and she told me, you have to talk with someone now, because we can call a psychologist to talk by phone. But when I arrive in Paris, come back to Brazil, I talk personally with the psychologist. So yes, we have this kind of help.
Oh,
let's come back.
So
Great.
cool. Thank
we
you.
have another question for you, Dr. Liliana, from the audience. She is asking, Dr. Liliana, how do you think students and future doctors can get involved with MSF and work with them as doctors? I think she would like to ask you, how is the selection process to enter the MSF?
Well, it's important to know that not only doctors that work with MSF. Yes, we have physiotherapists, we have a logistician. I always said that the logistician people is the most important people in the project, because if we don't have the logistician, we don't have hospital, we don't have surgeries. So we have a lot of professionals, not only doctors. But as a doctor, you have to finish the medical school. Unfortunately, MSF don't receive students, and you have to finish your residency. For example, in anesthesiology, we have 3 years of residency anesthesiology. So after this is allowed for the doctor to go to the project. And first of all, you have to speak English or French. And you have to do in the country you are. They call this assessment center. So you have to stay 1 day in an MSF office, doing a lot of interviews, tests. We have to talk with a psychologist as well. I think the first point is this, because we have a lot of people that has a lot of titles and very skilled people, but don't have emotional to be there. So it's because it's not easy to be there. It's not easy to be to live in a house with a lot of people, different people. Abu Abed know what I'm talking about. Probably always have some problem because you have to live with that people that you never saw, you never live with. So there is a lot of people that's difficult the behavior is very difficult. So first of all, you have to talk with the psychologist, and you have to talk English or French. I already did a French mission, and after this I did 10 missions. So if you talk Arabic, is much more important as well. And I think is this. There is something else to say, Abu Abed, about the selections.
No, I think as Liliana said, I mean, it's not only just doctors. Yes, doctors without borders, but yes, nurses, paramedics, psychologists, counselors, logistic team. I mean, finance, admin, HR, consult. So I think it's really these people make our lives, doctors, very easy. The logistic team and the administrative team, they make the life easy for us. So again, it was. I mean, it's thank you, Liliana, for sharing this beautiful memories of Palestine. And I mean, you made hundreds of patients smile in Palestine. And I mean, everyone still remembers Liliana up to today. They remember you all, the team, the medical team, the non-medical team. And I'm sure patients still remember you. Thank you very much.
You're welcome.
Now I'll make a question for Amin. Amin, what's your type for the students who want to study these topics that you talked to be prepared to deal with these situations?
Well, if they want to know more about these situations, how to deal, I prefer them to read from the best sources, like the United Nations and their policy, how they publish it. And do not only read from the international agencies like the CNN or BBC. Also check the local websites and local reports. Maybe they will find it in Arabic, but they try to translate it, because if they watch only from one side, they will only see one face of the fact. So you have to see both, and they have to compare, because not everything we see from one part is going to be true. We have to see both.
Okay, thank you. We have a next question. It's for Dr. Mohammed. Please, do the hospitals or healthcare facilities usually be safe zones in conflict regions?
Actually, it's it's supposed to be safe. Because I mean, this is international conditions that it has to be safe. But actually, sometimes in some situations in Gaza, some of the hospitals were bombed. I mean, damaged, and even in Afghanistan, as Liliana mentioned, in Kunduz as well, or MSF hospital was bombed. So it was. I mean, it's supposed to be a protected area, but sometimes during conflicts, it could be as well. Sometimes it will face some bombing or shelling, which can have a risk on the patients and the medical team working there.
Okay, and when we have like bomb or something like that in this place of conflict, the patients have to seek medical assistance, or do you usually go directly to the disaster site and help the victims, or someone have to bring the victims for the hostile area?
I mean, it works both sides. For example, in the wars in Gaza, I mean, we had the team MSF team present inside the hospital, working beside the teams of the hospital. I mean, in the emergency, in the OT, they were working. So they were inside, they were receiving the patients directly. In other countries, in MSF, they were picking the patients. So it depends really on the country and where MSF is working. But in Gaza, no way, our teams were inside the hospital, receiving the patients and operating on the patients directly, as Liliana mentioned in her presentations.
Another thing is important to say that, for example, in all missions, we have the head of mission, we have the project coordinator, we have Abu Abed, like a medical coordinator. So sometimes I was in the hospital, for example, when I was in 2014, I was in the hospital with a thoracic surgeon, and it's not allowed for me to come back to house. So I have to sleep, go through the night inside the hospital because of the security. So it's very, very important for the doctors, the nurses, to respect the rules. So when the medical coordinator, the project coordinator, and the head of mission said, no, it's not allowed to do this or to do that, we have to respect. And if the people, even is the surgeon, we have only one surgeon, but his surgeon didn't respect the rules, he had to come back to his country, because the security is the most important rule that we have to, because our goal is to protect all of us. So this is very, very important to keep in mind.
Oh, thank you.
Normally, for example, in the morning, we have a briefing with Abu Abed, we have the briefing, a security briefing with the logistician, with the HR, we have all the team together having the briefing, talking about the security. So sometimes during the day, we are in the hospital and something changed. No, it's not allowed for you to come back to the hospital, and you have to stay in the hospital, and you have to respect this.
Okay, understand. Yeah.
Dr. Liliana. We have another question for you from the audience. How it was for you, Dr. Liliana, the decision of looking for an opportunity to be somewhere like the war zone, being a young Brazilian woman and doctor?
Well, I never had any problem to be a Brazilian woman in the conflict zone, because the coordinators in the MSF talking a lot about the security. And for me, I didn't have any problem. Only that one I told in Pakistan, because you have to respect the culture. So it's not allowed for me to take a picture with a young boy. But as a woman, I never had any problem with this. Fortunately, I didn't have any problem to be a woman, to be a Western woman, a Brazilian woman, anesthesiologist. Of course, maybe it's more common to have a problem like a woman sometimes here in Brazil as anesthesiologist, and we have a male surgeons instead of there. But of course, I only stay in the missions for only 1 month, and it's very the time is very fast. But as a woman and a Brazilian anesthesiologist, fortunately, I didn't have any problem until this time.
Okay, I have a question for Dr. Amin.
Yes.
Well, first of all, I would like to congratulate to all of you professionals for the hard work that you've been doing. It's such an honor for me to be here. So Dr. Amin, we're talking about countries in conflict. We're talking about war, bombing, people dying every day, countries that are facing horrible things day by day. But now the world is talking about COVID-19, that the world has stopped to talk about it. And countries as USA, England, and Brazil are often talking about the vaccine. So what are the perspectives for those countries in conflicts to have the vaccine in the next few years?
Well, especially the low-income countries, as Syria or the countries I spoke about, they will wait till the big countries like the high-income countries to help them to give the vaccine or to spread the vaccine, distribute the vaccine to them. So like Syria, it will be, as we know, it will be the last one who will take the vaccine. So it will be a long time to receive the vaccine after all countries will receive that. Am I right?
Thank you, Dr. Amin.
To say something about this question?
I think Dr. Muhammad, he can help me with this too. Am I right, Dr. Muhammad?
Yes, I mean, you are totally right, Doctor. I mean, it's, I mean, you are, I mean, Gaza, Palestine, Syria. I think a lot of countries in the Middle East, Yemen, Iraq, I think these countries will receive the vaccine after everyone is vaccinated in the Western countries. And I mean, North America, even in Latin America, there will be in South America, there will some countries that will not receive as well the vaccine. And that's why MSF, we started to speak about to advocate for the vaccine for these countries, Middle Eastern countries, the conflict zone countries, that everyone has the right to receive the vaccine, but unfortunately it will not be very soon, as Mr. Amin said.
Okay, I also have a question for Dr. Liliana. Dr. Liliana, based on the historical international Brazilian support around the world, do you think that being a Brazilian helped you to reach places that maybe other nationalities wouldn't be so welcome?
Yes, sure. Yes, normally when we receive an email asking for anesthesiology surgeon, normally we have, for example, the citizenship. It's one of the first questions about this. And normally I don't remember any place that's not allowed for Brazilian people go. So this is very, very good. The first time when I went to Gaza, I have a funny history because I had to cross Erez. Erez is one of the interests of Gaza. And we have Hamas and Fatah, you know, and we have to do checkpoints. And when I show my Brazilian passports, the first they ask about the football, the Ronaldo, that time you don't talk too much about Neymar. And normally I always travel with Brazilian flag. And normally I put in my luggage. And this, yes, it's true. Sure, to be a Brazilian is very, I have a lot of friends in MSF that's from United States, from Germany, that's not allowed for go to some countries like Iraq, for Palestine. They want a lot to go because, for example, when I was there 3 times, but all the times I have to answer, for example, the name of my father, the name of my mother, the name of my grandfather, the name of my grandmother. So it's very hard for them. So some countries, some citizenships not allowed to go inside some countries. And normally when we arrive in Jerusalem, they ask us if we want to stamp our passport. And when we cross the Erez, they ask again if you want to stamp the passport or not, because we can receive a small paper. Because, for example, sometimes in some places, if you, for example, you went to inside the Gaza or inside Iraq, and maybe in the United States, you can have a problem if you show your passport with a stamp from Gaza. I didn't have any problem because when I was in Pakistan 2010, I arrived in Brazil, stay 5 days, and after I go to the United States, and I had a stamp of Pakistan in my passport, so I didn't have any problem. But sure, to be a Brazilian is very easy for us because we can go any place, to any place.
Thank you, Doctor.
I have a question for all the speakers, actually. I recently heard about a report of the first exchange of an Indian students to Pakistan, which are countries that have a great rivalry. So do you think that exchange are a way to bring greater cultural acceptance or not?
It's for me?
Can be for you or I mean. For all
Because
of you.
I understand the sound's not so good.
Oh,
Dr.
sorry.
Abu Abed, you can answer because I didn't heard.
You ask again, Luisa?
Yes. I can ask
Can you
again.
repeat again the question, because it's exchange of students, you mean, between, I mean, let's say Brazil and Palestine or something like this, or?
Yes, yes.
I mean, in Palestine here, I think they welcome everyone. And I think if they are Brazilians, they are most welcome. I mean, as Liliana mentioned, I think Brazil, because it's not involved in any political, I think, big issues, I think they are very welcomed in the Middle East. This is what, as well, the population, they expect them. I mean, they respect them. They are friendly towards the Brazilians. Yes, there are some nationalities which are very difficult for them to come to Middle Eastern countries. Exchanging, I think it will be good. I mean, initiative to have a kind of agreement or a kind of discussion with the universities in Gaza, because there is universities in Gaza. There is universities, of course, in Brazil. Why not to exchange? It happened between Gaza and some students from Italy, from some other countries, Malaysia. There were some exchanges. And I think it's very good for the students to have this kind of student exchange, to spend time in, especially medical students or medical faculties.
Yeah, great. I think the question is not very clear in the beginning. I was talking about the first exchange between India and Pakistan. So are countries that usually don't go to another, and now students can go between them. You understand?
Okay.
Andressa Madison, do you have more
Oh,
questions?
yes. I have one more question to Dr. Liliana. Is there any kind of preparation for professionals before going the field, or is just like, okay, I'm a doctor, I know how I can help you, and I'm going and discover there how to act in conflict zones, or you have like a preparation before, I don't know,
Yes.
like course or something like that?
Normally, when we prepare the mission, we receive like a dossier. For example, my first time in Gaza, we receive a welcome to Gaza, welcome to Gaza Strip, welcome to Afghanistan. So I think more important than should be a doctor, because of course, when we are prepared to go to the mission, MSF already know that I'm a doctor, that I'm an anesthesiologist, I have the capacity to work. They read my CV, but the most important is to know how I will manage the other problems, not medical problems. Yes, because for example, if you go to a first mission and there is any problem, I have to report this, for example, to Abu Abed. And if Abu Abed saw that some doctor has any problem, any technical problems, probably they have to do, because when we finish the mission, we have to do an end of mission report. And the medical coordinator writes as well a medical end of mission report about that doctor, about the nurse. So normally this is not the biggest problem. I think the most important when we go to the first time to a place is to read like a dossier they send to us, like welcome to Iraq, welcome to Gaza Strip, welcome to Afghanistan. Is a brochure, and in that papers they talk a lot about the culture, about the history, because it's very important for you to know who is who. Yes, because for example, when I went to Iraq, for example, I was in Kurdistan, and it's a very dangerous place, so we have to know where we are. So we have to read this. Normally we have some briefings by phone or personally, maybe in the office in Paris or in Jerusalem, in case of you go to Gaza. And normally we have, if you have any doubts, you can talk with the medical coordinator. Now I can send an email about specifically of the project. So all of the coordinators gave us a lot of information about what will I will receive, I will see in the field in case of the anesthesia machine, in case of the ICU, if we have about the food is important for you. It's important to know about the dress code, because in some places it's not allowed for you to show your hair. So this is very important. So I think it's more important than know that you are a doctor, and if you know how to manage a illness patient, to know this before, because this is very, very important, because it's directly linked with the security. You understand what I mean?
Yes, understand. Yes. Oh, thank you so much. So I think we have the time, so I will need to finish this QA questions. So much thank you again, Dr. Lilian, Dr. Mohammed. I mean, thank you so much. It's amazing to have you here in our Congress. So now we will have a little break, like 10 minutes, and then we're back with a lot of more lectures. So 10 minutes to take a breath and welcome someone and back. Okay, everybody?
Okay.
Thank you so much.
Thank you so much.
Thank you.
Bye
Thank you all for your time. Bye.
Bye-bye.
Thank you.
Hello, everybody. Everybody's listening to me. Let's back to the break. Everybody here?
Yes.
Okay, so let me.
Hello, you all.
Hello. Oh, I would
Can we
like
talk?
to
Or
just I talk just a little bit first. 1 minute. I would like to remember that our participants in the Congress want 2 weeks of free use of the onboard platform. To do this is just to fill out the form that was sent by email. So just look your email and make the forms, and you win 2 weeks of the use onboard platform. So now I'm here one more time to introduce for you our fourth speaker of this day is Dr. Everybody's listening to me? Yes, I'm listening. Everybody here?
Yes.
Okay, so let me. Okay, so I will introduce the fourth speaker is Dr. Ricardo Cabral. So he's Ricardo Cabral Santiago, Master Clinical Medicine and Biomedicine in Santa Casa, Belo Horizonte. His specialization in gynecology and obstetrics and works at RCS Cuidados de Saúde. So now it's your time, Dr. Ricardo. Could you speak, please? Thank you for your participation.
hello, hello, you all from all over. Hello, Luisa. Hello, Andressa. Thank you very much for the invitation, for speaking and exchanging experience with you today. Hello, Liliana. I'd like to introduce myself just for 1 second. And first of all, I'd like to thank everybody in the beginning of these lectures that we've been seeing today. It was great, and it's great to hear your experience as well, Liliana. Thank you very much for exchanging it with us. What I'm going through right now is I'm sorry. Can you see my PowerPoint presentation?
Yes, it's working. Okay.
That's great. So I'm a physician from Brazil. I've been working in different places all over the world for a few years. And for 8 years now, I'm taking place here. I'm working as a chief medical officer in a project called Eu Saúde, which is a telehealth project. And when you invited me to come, it was an honor to be part of this. And I thought that we should discuss this universal care. I am a huge fan of primary care health, the system and the basis, this concept of primary care. And so I believe that to primary care to work very well, we should address also another very, very difficult and important problem, which is universal access. We know that Brazil is one of the most important systems in the world that has universal access. And this is the basis of our system, which is called SUS, Sistema Único de Saúde, which should be something like the unique system of healthcare. In Brazil, we have 160 million people depending on this system. And we also have something around 50 million people which has private care, where they have different ways to hire this private care, but they have private care and they do not use the SUS or the public system with health issues. What we want to share is to thinking, how should we think about universal access and the importance of telehealth or telemedicine, as it's used to be called, and how should we compare these two different things, in my belief, telehealth is probably the better way, the most important way, and a new way to do and to provide universal access to healthcare. By WHO, World Health Organization, telehealth is when we have delivery of healthcare services and where patient and providers are separated by distance. Telehealth use ICT for exchange of information for the diagnosis and treatment of diseases and injuries, research and evaluation, and for the continuing education of healthcare professionals. Telehealth can contribute to achieve universal health coverage by improving access for patients to quality, cost-effective health services wherever and whenever they may be. This is particularly valuable for those in remote areas, vulnerable groups, and aging population. We used to think that aging population would not be aware or would not be able to use medical devices or cell phones or things like that to be able to achieve telehealth. But in our experience in Brazil, and I believe that EUSaúde is one very important project about telehealth in Brazil, we've been managing to be available to take care of more than 14 million people for months during the COVID-19 crisis. And so we have a huge experience and very solid basis of processes that I'm going to share with you right now. And I really believe that telehealth would be one huge improvement in the world health system, enabling people who do not have access to have access to healthcare. And as we were talking, aging people do have ability to talk to physicians, to talk to nurses, to talk to psychologists and so forth. And we believe, or we used to believe that they would not be able to do, but in our experience, we know that they are able to do. Of course, it's more difficult and usually it takes more time to help them to initiate the contact, but this is another issue. Take a little bit more time. It's not important when we are talking about a huge and a very important, massive coverage of healthcare. When we talk about healthcare and telehealth in general, we must know that we will have to face different issues. We have to talk about telemonitoring. We have to talk about medical connection to discuss cases, to improve the efficacy and to improve the assertivity of the medical care in primary care or to physicians with different specialties. We have to talk about telesurgery. We have to talk about telemedicine as it is most known. It's a medical consultation using a communication platform. We have to talk about teleorientation, and we have to talk about telediagnosis. This is the huge complex of telehealth. But what I'd like to talk about today is the importance of telemedicine and teleorientation and telemonitoring, because these are the basis, those three items are the basis to talk about primary care using telemedicine or telehealth. When I want to say that we could use telemedicine or telehealth to primary care, we should also discuss about the transformation of the care model itself. We have to involve patients. Since 2011, I was living in Portugal on that time, and my project was enrolled in University of Oporto, and we were discussing the patient empowerment, patient engagement, and this is the basis of transformation of the care model. We should never believe that the system should take care of people. We must believe and we must make sure that the patient has the power and the engagement to do the change. The system itself is just there to take care of some specific situations, clinical situations, acute care, chronic care, and education. If we do education and if we do generate engagement and empowerment to patient change, they will be able to make the change, to make it happen in a different way. And so why to talk about Brazil's distribution of doctors, and why talk about use of telehealth? What's the importance of that? When you see a graphic like this, an image that shows the number of physicians available to take care of the people through Brazil, which is a continental country, as we know, we are more than 200 million people. And so everything that we talk about Brazil is huge, it's very important. But we can see clearly that in the north part of Brazil, there are not enough physicians. There are not enough health professionals in general. We are talking about not only physicians, but we are talking about nurses, psychologists, nutritionists, and so forth. And that's why I believe that if we think that the use of computers or mobile phones or some other ways to communicate should generate universal access, that's what we believe that is going to be the great change of telemedicine in the world. And that's why the company that I worked for, together with many people, and the academic environment as UniBH, which I'm pleased to be part of in the health lab. And we believe that we can do the change. We can make it happen, as we used to say internally, if we use telemedicine to universal access. If we believe that telehealth is, we are talking about availability of care, time consuming, less time consuming, about traffic jams, about logistics. When we talk about logistics, we also can talk about logistics for patients and logistics for medicine, for physicians, for hospitals, and so forth. And so when you talk about logistics, we are talking about everything. We know there are hundreds of papers that states telemedicine is cheaper than presential care. We can talk about to change the way we see the geographical challenge all over the world. When we talk about telehealth everywhere, we created internally this, what is our telemedicine cabin, which is to be spread. If we do spread this in everywhere, when I say everywhere, I mean everywhere that people are, that people need, we will be able to connect them to good healthcare. We will use devices. Yes, we know that we will use devices to collect a better or a safer or a more accurate complex of data from the patient. When I say data, I mean telemetry. I mean to collect a proper blood pressure, a proper sound from the heart or from the lungs that we can do using Bluetooth stethoscopes. And so if we do deliver healthcare, we can do it as cheap as having cabins all over the world, and they will connect to physicians all over the world to take care of these people that they need the most. When we talk about how should we do it, what I believe, and actually it's not my belief, it's a word belief, we should talk about project management. When we talk about project management, we should define who is going to take care of who. And internally, this is just an internal piece of paper. We created an exact kind of primary care virtualization. We have the patient navigation system, we have the caretaker, we have the attendee, which we will receive the call and which will also call the patient when it's needed, using a line of care, a clinical path, which we will make the patients go through, helping them to do great choices. And that's what I believe that will make the change. If we do have a patient change way of life, we will improve health. And they have to have education to do the best choices in the right moment to be able to move forward. When we are defining the process of care, we are also talking about lowering costs. And so we also have to say when and where we should take care of people. And I'm using WWWHH, project management, which stands for who, when, where, how, and how much. But I'm trying to say that when and where is very important. When it's needed. It's not about us to define when a patient needs care. We know that we should try to teach people that they look for the system when they really need it, because the system has limitations. And if the system has limitations, we should try to make it useful. But we also should try to make it really able or capable of taking care of so many people. And so we should teach people to look for the system when it's really needed and where they need it. It's not about us to define it, but when we see another aspect of the same when and where, we should take care of people where they need, when they need, how they need. And when I'm using where twice to say that we using different care flows to different professions. And so where and how is also about who is the physician, who is the specialty, which specialty we will use, who is the professional that will take care of that people or that person in that specific moment in time when they need for that specific needed. And so that's why we believe that we should take care very well of process care to lowering costs, enabling us to give care to a huge amount of people, enabling more people to have access to healthcare with less costs is also part of this universal change of healthcare, which will enable them and will enable the system to take care of them. This, I'm moving to a spreadsheet. Actually, it's not a spreadsheet, it's a viewer. We are using Tableau as a viewer. And I just want to share some data that we collected through our project that we managed to take care of something about 80,000 people with COVID-19. And this is how we collected them, and from different states in Brazil. This is how the results of the tests came through. This is very, very interesting because, as we can see, when the tests were not available or were not, they didn't have access to tests, when we tested, it was probably positive because we have a very important and rigorous protocols to ask for the test. But now, usually, the test is negative, and that's why it's using more spreadly. We don't have to manage to ask less tests because it's more the access now, it's much easier and so. But this is the way where I would say that telemedicine is of huge importance. And this is the most important graphic of our experience so far. As we can see here, and this red line is admissions to hospitals, and these green lines are no admissions. When we started to take care of people with telemonitoring, it was something around July this year. The amount of admissions, it was completely different. And that's very, very important because this is to lowering the costs. In our experience, we could do it without increasing mortality or without increasing morbidity of these patients that were not admitted to hospitals, just because we could do telemonitoring for them, and just because we were safe, because we knew that if they need, they would have us just in time. So it was just a matter of getting us in the WhatsApp or in a phone call, we would be there to answer them. And so that's why we were sure that we were doing the best in terms of care management, but also in terms of cost management. And this is a very important vision of our experience so far as well. And this is just to show that these are symptoms for, I'm sorry. These are the symptoms that we got from these 80,000 people in general. This image shows the distribution of symptoms of those patients who were admitted. And this shows the symptoms of the patients who were not admitted to hospitals. And that's how we will manage the future. We will manage the future getting knowledge, using knowledge from experience that we have, from different moments in time, but we have to get to know, we have to collect data from every experience we have. And if we do so, we will be able to change the world. And what I wanted to show is that using telemedicine, we could do a very, very important picture of medicine, of care, of medical care, as this picture shows. The decrease of hospital admissions, the increase of patients who were not admitted using telemedicine. And that's why I believe that using telemedicine, we can change the world, we can make it different, because we can collect people from Africa, from Asia, from wherever needed to be cared from wherever we have the condition to provide the services. And so I really believe that using telemedicine, we will be able to change the world. And that's what I wanted to share with you. And thank you very much to listen. And I'm here to talk. And I know that there is a Q&A session later. And so I'll be here to answer everything you need. Thank you very much.
Thank you, Doctor. We, the Global Health team, thank you for this great talk. But unfortunately, our time is short, but we have to separate some questions, and I will make for you now. The first question is, after this spectacular lecture, we see how telemedicine can be useful tool in the democratization of access. However, we know that the developing countries, many people still do not have access to the internet. So what will be the strategies to overcome this obstacle?
When I showed you that cabin, it's just to create a point of care. They do not have to have universal access to internet, but we can create points of care using satellite signal. We're using different technology to make it happen. And so I believe it's doable. But there is a technology in which everywhere they have access. Not everywhere, but it's even more used than internet, which is SMS. And we can do almost everything, collecting data and sending data, sending medical tips, or creating people that will help us on the field using just SMS. I've been trying that years ago, and it worked very well. We can send data through SMS, which has a bigger or more important access than internet itself.
Okay, thank you so much. I have one more question. Do you think the telemedicine can get in the way of such as important doctor and patient relationship? We can break this relationship because it's telemedicine, not one person. What do you think about that?
Andressa, I can ask you a question as well. Can I do it?
Okay.
Okay. So do you believe that our relationship with our patients is created by the way we talk, by the way we treat them, by the way we care about them, or through where we see them?
No, I think it's everything together. It's not
Yes.
just one thing. It's the context.
Yes, and that's my belief as well.
Yes.
We should and we can have a good relationship, medical patient relationship, using video or phone calls. It's
Yes.
just a matter of taking care and being polite and so forth. And so I believe that this is important, yes, but this is not the only reason to have a bad medical patient relationship.
Yes, and I think some care is better than
No care.
So low care, yes.
Yes.
Okay, thank you. It's just 2 questions because we have a really short time. So
Sure.
Thank you so much. It was amazing. So now I will continue the Congress. So Edson, can you hear? Are
Thank you
here?
very much. See you later.
Thank you.
Yes, thank you. Can you hear me?
Yes, okay.
Okay, so now we're going to talk with Dr. Fabio Gomes. I'm going to introduce him. Dr. Fabio Gomes is a legislative consultant of public health of the Chamber of Deputies. He's a professor graduated in medicine at the Federal University of Pernambuco, Brazil, and also a master in social politics and PhD in political science. Thank you so much for your time, Dr. Fabio. You have the word now.
Thank you very much. I'd like to thank you, the organization of the Congress, for the invitation. I'll start sharing my screen, okay? Yes, can you see the slide?
Yes.
Okay, I will.
Thank you.
Yes, and the topic will be about the legislative power and health in Brazil. And it has something to do with the international global health team, because every country has to deal with its legislative branch in order to approve health policies. And maybe the experience of the Brazil may be useful for other countries. So I'll talk a little bit about the context of the Brazilian Congress in which Brazilian Congress operates, a little bit about the functions of the legislative power and health, the functions of oversight, dissemination of opinions, and of course, production of laws. Also, I'll talk a little about the health agenda in the Chamber of Deputies and some challenges related to this issue. About the context, I'd like to mention that in Brazil, we are a democracy and we have a division of powers, the executive power, legislative and judiciary power, and the systems work with sharing power in order to construct public policies. Another issue is that we have in our political system a coalition presidentialism, and it's characterized by the president elected by the majority of the people, and the president usually shares power with the political parties through offering positions in his or her cabinet, like the ministerios we call here. We are also a federation, so we have to take this in consideration. We have subnational units, and of course, for health, we have the unified health system, the SUS. That's a universal system characterized by offering health services for all in a hierarchical way, with a regionalization and also with a lot of community participation. I think that my camera is flashing, but okay, I'll go on. The functions of legislative oversight. I'll give you some examples of this function related to health. For example, we have in the legislative branch a lot of investigative commissions. We call here CPIs. I can cite the CPI of the medicines, was very, very important to establish public policies for the medicines in Brazil. A CPI about the organ transplantation. Another example, we have special commissions. Right now, we have the COVID-19 Commission that is doing a lot of public hearings and to oversight the response of the executive power, the response to the pandemic. Another example of oversight is the SUS quarterly report, in which every 4 months, the Ministry of Health must go to the Congress in order to talk about the SUS. Unfortunately, this has not been, this is not happening in a regular manner. We have another examples of oversight in health when the congresspersons issues information requirements. So, for example, the Minister of Health has 30 days to answer the questions formulated by the deputies and senators. We have plenary sessions when the congressperson discuss lots of health issues. Another function, a dissemination of opinions. We have a project at the Chamber of Deputies called e-Democracia. That's a site where the public can go and watch public hearings through the internet, and they may interact, send questions through the chat. We have public hearings and related to health, like categories of health professionals. They're very frequently, they go there to the chamber, to the Senate, to talk about their interests. We have audiences related to the interest of patient groups like people with diabetes or lots of other diseases. I remember right now the Tobacco Control Initiative, when the legislative had to approve the international resolutions for tobacco control, and this was a very successful example. And I have now to mention the functions related to production of laws. And here below are some papers that I have worked. This number one is in this website, Translating the Americas, from the University of Michigan. At this link, you will have the entire paper. That this paper talks about the procedures of lawmaking in Brazil. And the second paper talks about a specific case study related to the policies, social policies, in the case education and health funding. So during these studies that I mentioned in these papers, I could observe some patterns of relationship between the legislative and executive powers in the production of laws in all areas of policy and also in the health field, and was observed some patterns of interaction, like lots of cooperation, but cases of leadership of one of those powers, and also situations like impasse, like a lockdown. Yes. And it was concluded that distributive conflict and governability issues were in the root of many kind of behavior or relationship developed between the legislative and executive powers. And in this letter B, I would like to mention some cases of production of laws that were very important and counted with the participation of the legislative. Like the very creation of SUS was created by the Federal Constitution of 1988, and the legislative had a very important role hearing the society demands of that time. I would like also to mention the case of health funding. That's a huge problem in Brazil. And since the beginning, since 1988, since the creation of SUS, the system faces a lot of financing crisis, and most of it due to kind of uncertainty of the criteria of the federal funding. We had the criteria, of course, but it was not enough. And this is an issue that goes on and on. The discussion, the debate in Congress goes on and on. And also the example of the COVID-19 response, the legislature was very fast to establish virtual plenary sessions. So very rapidly, a new law was approved in 2020 specific to the COVID-19 pandemic. And in that law was included, for example, the question of the use of telemedicine in this pandemic, because before telemedicine was not regulated in a law, and a lot of other services that were allowed by this specific law related to COVID-19. And here is just a table to show some laws produced by the Congress, the Brazilian Congress. And here I would just like to highlight that we have three legislative pathways, like the constitutional, that produce constitutional amendments, a very high rank kind of norm. We have the complementary pathway that produces complementary laws that are laws requested by the Constitution. And we have the ordinary pathways that produce ordinary laws. And this last one represents the majority of bills introduced. You can see here more than 17,000 bills introduced, ordinary bills introduced for all themes. And for all legislative pathways, we had in between 1999 and 2006, more than 21,000 bills introduced. So I just will show the health-related bills. In the same period, were presented 5,000, more than 5,000 bills related to health, and 268 were passed into law. It's just to show the amount of production related to health compared to the general production. And here is a model that was used to study the relationship between the executive power and legislative power. And I will show very rapidly that this model is has a systemic and strategic approach. And we have here the demand for policies, which are the input for the system. And the model considers the structuring constitutional rules, the actors, institutional and individual actors, the decision places. We have the chamber, have the Senate, the Congress, that is the sum of the chamber and the Senate. In each place we have the plenary, and we have standing committees, and we have special committees. We have another resources like legislative resources, like the different kinds of bills. We have human resources like all personnel working at the chamber, for example. Material and time is a very important resource. And we have the agenda setting that is connected to the electoral demands and to normative demands. Electoral comes from the elections. Normative comes from the very Constitution, because the Constitution has a lot of governability and accountability issues. And the Constitution also have a lot of policy guidelines. For example, health, education, all are constitutionalized policies. And it's more difficult to change these policies because they are represented in the very Constitution. And you need more resources in order to change anything related to these policies. And finally, we have the flow in Congress of a bill. We have different phases: introduction, the consideration, the conclusion, where we observe the different kinds of relationship, and the result, the transformation into norm, rejection. We may have non-decision, and after that, everything may influence the cycle again as a feedback. Here is an example of the health agenda in the Chamber of Deputies of Brazil. We have this study in February of 2019, and we used a typology developed by the research group. This paper has all this information. But now I just would like to show that in February 2019, we had almost 2,000 bills being considered at the chamber, and a lot of them were related to prevention, the red bar, and also with the rights related to health, and also with the blue one, the healthcare bills. These would be the typical health bills. But this typology also considers, as I said, the prevention, the rights related to health, and also management and other resources. That was just an example. If you are interested, please go to this paper. And I'm almost finishing. I would like to talk about some challenges related to the legislative in the health field. And as you can see, I have underlined a lot of themes. These underlined themes are those that also have interest for the international health arena. So the first group of challenges, I would like to mention the SUS. We need to improve primary health care. And these challenges, all those challenges are being discussed at the Congress. Sometimes one specific issue will gain more importance, but I can tell you that all these issues are present in some bill. Some bills are not very active, but others are active when some deputy or senator or even the society calls for some action. So it's very important for the society to know what issues are present in the bills that are being considered in Congress. So as I was mentioning, we need to improve primary health care. We need to still discuss funding, the SUS funding. The management of SUS, we have a lot of problems with regionalization. We see that it's not easy for the managers of the federal, state, and municipal level to agree. Right now, during the COVID crisis, we saw that many times some state was doing something and the other was taking another direction, and the federal level did not set some general guidelines, did not establish some general guidelines to be followed by the other managers of the SUS, of the federation. Another issue is the health professionals for SUS is not being debated. Generally, the debate is very fragmented by category, like community health workers or physicians or nurses, but I don't see integrated debate like human resources for the SUS. We need a lot of transparency, like that quarterly report that's not being reported regularly at the Congress. We need long-term planning for SUS, like a 10-year health plan. We don't have it. We just have a 4-year plan, the pluri-annual plan. And even this plan is not being followed by the society or by the Congress. Regionalization, I already mentioned, and I'll just mention very rapidly epidemics, international sanitary regulation. We need to improve natural and non-natural disasters, epidemiologic transition, environmental changes, trade, food security, supply chains for emergencies, new technologies like telemedicine, health diplomacy, and we also need to discuss the information among other issues, many other issues. And I would like to invite you all to this seminar, December 2, 3, and 4, about the role of the legislative power in the evaluation of public policies. It will be broadcast by the Chamber of Deputies YouTube page, and also at the eDemocracia website. Yes, and thank you very much. Here's my contact. If you have any question, I will be happy to answer. Thank you.
Thank you so much, Dr. Fabio. Well, due to our short time, we're going to ask you only one question, okay?
Okay.
We would like you to give your opinion facing, we live in a continental country, as said before, and due to that, we have lots of problems when it comes to our unified health system. So the COVID-19 showed us the importance of having SUS in Brazil. So how do you think that SUS is going to be after the pandemic, and how our politicians must work on the insurance of giving SUS to the citizens of Brazil?
So could you repeat just the last phrase, please?
Yes, how our politicians must work to give us better SUS, better health in Brazil after the pandemic.
Yes, they must work in integration with the scientific evidence and with the societal demands, because this is what is needed for we having a better response to the pandemic, and we still are going to need a lot of integration of executive, legislative, and society in order to take care of this situation. For example, we have to have a very good response related to the vaccine. We need a very good strategy to offer the vaccine, and also to keep recommending the people to prevent themselves with the basic measures like using masks and using water and soap and alcohol in gel. Yes.
Okay, thank you so much for your time, Dr. Fabio. It was a pleasure to have you here.
Thank you.
And now our next speaker is going to be Dr. Hashimi Singh. She is a professor in the postgraduate program of international relations at PUC Minas. She has a degree in history from Delhi University in India. She is a co-founder of the research network on terrorism, radicalization and transnational crime at PUC Minas. And she's also an associate editor of Perspectives on Terrorism and works as a member of several international scientific and editorial boards, such as the International Journal of Conflict and Violence. Thank you so much for your time, Dr. Hashimi. You have the word now.
Thank you, Edson. Can you hear me?
Yes, I can.
Okay, excellent. Well, let me start off by thanking, first and foremost, the Global Health International Congress for their very kind invitation. I would like to say hello to my colleagues whom I share a platform with today in Brazil and beyond. And especially, I'm very, very happy to share this platform with my colleagues from the Médecins Sans Frontières, who I have a very, very warm association with, thanks to my own time in the field doing research on terrorism in various conflict zones. So I'm delighted that I get to share a platform with them again. But especially I would like to thank the students, because it's been a very, very hard year for all of us, but I think the students especially who are finding the isolation brought around by the pandemic difficult. And so this kind of initiative shows just how resilient students are, how resilient we are as a society, and that the human spirit can conquer anything when we set our minds to it. So congratulations for actually pulling this together at such a time as we are living. I don't have very much time, so I'm going to try to rush through quite a large amount of information when it comes to the idea of terrorism and health. We don't often think of the linkages between terrorism and health. And when we do, we often think of this in terms of the toll that terrorism takes on the health of a target society. We know that terrorist attacks present a major challenge to society. And in doing this, they place governments, the citizens of a country, the infrastructure of a country, healthcare systems under acute pressure. And all this is very, very true. But what I want to point out today is that the linkages between terrorism and health are much more intricate and complex. And this is something that we need to pay attention to if we're going to formulate better counterterrorism policy, better counter-extremism policy. Terrorist groups have a very long history of targeting healthcare workers, healthcare facilities. They also have a long history of providing healthcare for their own constituencies, not only the members of their own group, but also those that they consider the people that they represent or they fight for. Now, in the very, very short period of time, I actually want to approach this from three very distinct prisms or lenses. I want to first talk to you about terrorist groups that very deliberately target healthcare. Then I want to talk to you a little bit about terrorist groups that provide healthcare. And then I want to talk to you about terrorism in the time of COVID, because we see some very interesting responses from different terrorist groups right now as we are moving forward. Again, I will start off by saying that there are a couple of disclaimers in my talk. You will notice that a number of the organizations that I am referencing are Islamist groups. And this is not to say that there is only Islamist terrorist organizations that target healthcare facilities or provide these services. We have evidence of this trend right across all varieties of terrorisms, all religions, all ideological political leanings, but Islamist terrorism is something I work on, so I tend to look a little bit more at it. The second disclaimer is that I'm looking at terrorist groups, so sub-state actors. This is not to say that states cannot be terrorist actors and states cannot target healthcare facilities, because we have seen repeatedly that they do. I will mention some of this in passing, but again, my focus will be on the non-state actor. So with that in mind, let's take the next 15 minutes or so to talk a little bit about these three categories that we have. So the first one, terrorist groups that target healthcare. Before we even get into this, what do we mean by this? So here are some broad categories that we can identify. First of all, we identify violence against health facilities. Second, violence against health workers and health staff. Third, violence against those who are wounded and sick. The fourth, violence against medical transport. And finally, the misuse of health facilities and protective symbols. So when we talk about targeting healthcare, these are all the things that we are talking about by these particular groups. So let's start with an example. In June 2020, less than 2 months after the COVID-19 pandemic had started, there was a United Nations assistance mission report from Afghanistan that outlined how there had been 15 attacks on healthcare in Afghanistan alone in these 2 months. And in the study, they outlined how health workers were harmed, how health facilities were damaged in the targeted attacks. And these were attacks that were conducted not only by the Taliban, but also the Afghan government. In both cases, a number of these attacks were deliberate. In the case of the Taliban, for instance, 12 attacks were deliberate, and the remainder of the attacks were incidental harm. The same way we notice in this particular report that the Taliban in this period, in the 2 months after the start of COVID, had already abducted, kidnapped 23 healthcare workers in 7 separate incidences across 6 provinces and regions of Afghanistan. They had also done things like detonate a remote-controlled improvised explosive device, which is a nice way of saying a remote-controlled bomb, which was detonated in a private pharmacy in Nangarhar. They had injured 8 men in this particular attack, including a doctor who had been there from a nearby hospital. But the Afghan forces who were fighting the Taliban were also responsible. They were responsible for 3 targeted attacks and 1 incidental harm attack. And of course, we all know about the most abhorrent attack, perhaps, in Afghanistan's history on a healthcare facility, which was the assault that was done on the maternity ward in May this year, which left 24 people dead. It was a maternity ward, and the dead included women who were in the process of delivery, as well as children who were in the ward that were hurt or fatally injured in that particular attack. So, and nobody has actually claimed responsibility for that attack. So we see that this is a reality in many, many parts of the world, and groups like the Taliban in Afghanistan are one of the most notorious groups when it comes to targeting healthcare. Now, Afghanistan's healthcare system is perhaps one of the weakest healthcare systems in the world, thanks to the many, many years of poverty and war. There was a 2019 study by the World Health Organization that actually outlined how 4% of the national budget in Afghanistan only came from the Afghan Ministry of Public Health. 80% of the healthcare system is actually funded by foreign donors, and healthcare providers are a very, very important part of that funding. I want to remind you that the Taliban is an extremely conservative organization. They came into power in September 1996, and when they did, they started what is best described as a reign of terror over Afghanistan in the areas that they control, especially when it comes to the status of women. They have an extremely fundamentalist interpretation of Islam. And so as part of this, they have severely restricted women's movement, freedom of movement, access to healthcare, education, and employment. This has impacted female physicians, doctors, nurses. Some of them have continued to work because the Taliban has decided that male doctors cannot treat women patients unless they are relative. But that also means that female physicians and nurses are constantly harassed. Often they are beaten by armed Taliban guards who enforce morals. Male and female doctors in general are viewed with suspicion by the Taliban. They're routinely ridiculed in public. Women are attacked if they go into the street trying to look for medical attention for themselves or their children. There was an incident where a pregnant woman was forced to deliver her baby in the street because her husband was being attacked by the people on the street for trying to take her to the hospital. So there has been a percolation of this attitude into society. And this interference with the delivery of healthcare comes at a time when a lot of people require treatment for injuries because, you know, there is a situation of conflict, there is a situation of war, and the public healthcare system has collapsed. However, this also gives a lot of trouble for those of us who are trying to research this. Very few physicians are willing to discuss the patients that they treat for injuries. And there are a lot of physicians who are also collaborating with the Taliban in order to avoid reprisal. So there's a very, very murky situation that this attitude that the Taliban has gives rise to in the day-to-day of Afghanistan. Now, I should point out that, like I said right at the beginning, this disrespect for healthcare is not limited to non-state terrorist actors. The United States, for example, bombed a humanitarian run. In fact, it was Médecins Sans Frontières hospital in Kunduz, Afghanistan in 2015. And so, you know, we have seen incidences of states very deliberately targeting healthcare facilities, hospitals. We are focusing on Afghanistan at this particular moment in time, but we can also reference the Israeli state in terms of the Israeli-Palestinian conflict that has a very long-standing negative reputation of deliberately targeting healthcare facilities in West Bank and Gaza. However, one of the things we have seen is both by terrorist organizations, non-state terrorist organizations, and state actors, there has been a deliberate targeting of health and healthcare facilities and healthcare workers that have escalated for the last 10, 15 years. And this is very interesting. MSF director Stephen Cornish, at least at one point, highlighted how this is a pattern of disrespect. It's a deliberate targeting in many cases, and it's a deliberate negation of the rules of war. But what I want to point out here is this is repeatedly reflected in the actions of many terrorist groups, not just the Taliban, where healthcare workers are harassed, they're kidnapped, they're killed, healthcare services are targeted, vaccination campaigns are targeted. And so this is an increasingly problematic space. Now, the Taliban, who we've just spoken about, is a good case in point, but it's not the only group that does this. So let's talk about one more group that does this. One more group is Somalia's Al-Shabaab. Now, Somalia remains today one of the most dangerous places in the world for aid workers, and one of the most formidable obstacles to reaching people with healthcare facilities is the Harakat al-Shabaab al-Mujahideen, or Al-Shabaab. Al-Shabaab is a group that has been active in Somalia for a very long time. They also are one of the few groups in the world that declared a bayat, or a blood oath, to Osama bin Laden and Al-Qaeda, which was accepted. So they are a functioning, recognized associate of Al-Qaeda. And they have been routinely responsible for expelling aid workers, attacking aid workers, harassing aid workers. They have rejected campaigns of vaccination. And Shabaab permits some agencies to work under its control, but very little is understood about the attitude that Shabaab has towards the agencies it decides to let in. And how these agencies negotiate access to it is also something that they are not willing to discuss very publicly, because it's such a difficult space that they work in. They don't want to incur the wrath, if you want to call it, of Shabaab. They don't want to fall foul of counterterrorism restrictions or be seen to be supporting terrorists. So the aid workers and the aid agencies themselves find their position very, very tenuous. But in general, for the aid agencies that Al-Shabaab lets in, what it tries to do is it puts in place a very structured system of regulation. And that is done through taxation and surveillance in all of the areas that it controls. Shabaab actually has an office in its structure called the Office for the Supervision of Affairs of Foreign Agencies, which is dedicated essentially to dealing with foreign aid agencies. Under this particular office, they have a body called the Humanitarian Coordination Office that does the day-to-day regulating of aid agencies. So any agency that wants to work in an area trying to provide healthcare services to people needs to approach these offices of Shabaab. Permission is generally agreed at the local level with the humanitarian coordination officers, as well as local loyalists that the Shabaab employs. And these are the people who negotiate access. These are the people who collect taxes. These are the people who monitor on a day-to-day basis the aid agency activities. And there's lots of rules and regulations. Aid agencies cannot proselytize. They cannot, for example, have male doctors provide services to female patients. And so there's many, many restrictions. And generally, this sort of negotiation begins with a registration fee that the aid agency has to pay. And that goes between $500 to $10,000, depending on the size of the aid agency, the nature of the project, the location of the project, the kinds of relations that exist between the agency staff and the Shabaab officials. There's lots and lots of things. And these fees are essentially Shabaab's security deposit to allow these agencies to work in security in these spaces. But we have seen historically that Shabab does change its mind. So sometimes agencies are allowed to work, and then at some point the Shabab changes its mind and they are pushed out of these areas. And so this is something that is very, very interesting. What it does in every case is create a very unclear and volatile situation, which results in an overall negative impact on healthcare in the region. So this is one example, two examples of terrorist groups that very deliberately target healthcare. Let's talk a little bit about terrorist groups that provide healthcare. And the obvious example here is Hamas. Hamas is a very, very interesting case, primarily because its healthcare activities have evolved considerably from the time it first emerged in the first Intifada in 1987 in the Palestinian territories. And many, many people have argued that this evolution of its healthcare activities in many ways reflects Hamas's own, although it's incomplete, transition from what has been a militant terrorist organization to what is today a de facto government. Now, in this time, in these last 20 odd years or so, Hamas has gone, well, 30 years now, right? We're in 2020. Hamas has gone from doing something very basic like coordinating medical clinics that existed across the West Bank and Gaza, coordinating charities that provided healthcare facilities, to today managing what is a multi-million-dollar healthcare ministry, which employs thousands of people and has thousands, hundreds and thousands of beneficiaries. Now, we have to remember that Hamas has always seen healthcare and the provision of social service as part of its dawah wal tabligh. It's as a part of its religious responsibility to the Palestinian people. But it has been extremely impressive to see the evolution of Hamas's social welfare network. And healthcare is just one part of this social network. And it's no small feat, because Hamas has used its social welfare network over the years to garner legitimacy within the Palestinian population that eventually allowed it to be democratically elected into power. It's a different matter that the states of the world decided that they were not going to acknowledge that democratic result. And it was a very, very big mistake. But Hamas was officially democratically elected into power by the Palestinian people. And a large part of that was its social welfare network. By 2003, for example, it was estimated that 1 in 6 Palestinians received some form of support from the Islamic social services organizations that were run by Hamas. And the scope varied. You know, there was everything from providing money and housing to widows, to orphans, to providing reconstruction of housing services. And a lot of this was frozen in 2007 as a result of the elections, when Hamas's bank accounts were frozen. And however, once it took over Gaza, and there are, of course, lots of problems with that, it does have a very clear hold on the healthcare ministry, but it continues to also have zakat committees that operate in nearly every Palestinian city that it uses to dispense aid to those who need it. There's many, many Hamas affiliated charities funded from a large number of sources, and these are also Hamas also uses this to pull in cash and in-kind donations from wealthy individuals, local businesses, international donations, all for trying to provide social services, of which one of them include healthcare. And this goes to everything from medication, hospitals. I am trying to fund ICUs and so on and so forth. So it's a very, very deep involvement that a group like Hamas has. So this is one very good example of a terrorist group that has actually evolved into a de facto government, but that has also consistently provided healthcare for its own constituency. So with this in mind, let's talk a little bit very, very quickly about terrorism and healthcare in the times of COVID. And I want you to notice how different terrorist organizations are using COVID to create a narrative, to get legitimacy amongst their populations, or in some cases, even to try to weaponize COVID. Islamic State is a very, very good example. Now, Islamic State, very much like Hamas, has tried to create its own health services. And there's a paradox here, because after it rose in 2014, Islamic State bombed hospitals treating wounded civilians, it abducted, assassinated patients, it killed healthcare providers, it put very restrictive measures against women. But at the same time, they also tried very much to build their own healthcare system, and they tried to get people to volunteer from different parts of the world to come to this newly established caliphate in order to provide healthcare facilities to those people who were in this territory. So there's that very, very clear paradox in terms of how the Islamic State has behaved. But when it came to COVID-19, the Islamic State's response is very interesting. So the first thing, the Islamic State viewed COVID with happiness. You know, it was seen as a punishment from God against the Crusader nations. And the Islamic State actually encouraged its supporters to exploit the crisis of COVID by trying to launch more attacks against Western countries. Over time, as COVID spread, Islamic State seems to accept that the virus can also spread amongst Muslim communities. And now it started recommending that its members take precautions so that they don't catch the virus or transmit the disease. And they started providing very clear health guidelines, counseling that, and I quote, "the healthy should not enter the land of the epidemic, the afflicted should not exit from it." They had very, very clear directives on how to sneeze, how to wash your hands. In fact, to be honest, the Islamic State at one point had clearer instructions for its citizens and its supporters than Donald Trump's America. So that gives you an idea of how the Islamic State responded, as opposed to some states that we know of, including Brazil. At the same time, over time, the group has also managed to combine this rhetoric of precaution with strategic advantage. Now, so it very clearly asked its supporters not to travel, but it then asked its supporters who were already in Western countries, already in Europe, to exploit the pandemic to launch new attacks. And so this was something that was very, very clear. It called the pandemic the Crusaders' worst nightmare. And it said to its supporters, you know, COVID is essentially paralyzing the Western Crusader nations. They don't want to send soldiers to the Middle East where the soldiers can catch the disease. They're using their security forces to try to prevent mass gatherings and contacts between people. And therefore, this is the ideal time for ISIS fighters to escalate their military operations against the apostate West, as well as to increase the attacks against their enemies in Muslim states. So they actually encouraged their supporters to conduct attacks like Paris and London and Brussels. And the fact that this narrative was something that was being heard was very, very clear. In April 2020, for example, this year, the German police arrested 4 suspected Tajik members of the Islamic State who were trying to bomb a US Air Force base that is located in Germany. So it's not just that the Islamic State was talking without an audience. An audience was listening and taking this on board. It's worth noting, and this is the last thing I'll say before I start wrapping up, it's not only jihadist groups who have been trying to exploit the crisis. Far-right groups, white supremacists, and others who have extremist right-wing ideologies have also demonstrated their intention to exploit COVID-19. We know about the FBI who shot and killed a white supremacist in the United States who was trying to car bomb a hospital that was treating COVID-19 patients. We also see far-right extremists have been very, very active online, engaged in hate speech. But more importantly, it's very important to remember that it's the far-right white supremacists who have a much more clear agenda of weaponizing COVID-19 than the Islamist organizations. So there was a neo-Nazi website, a neo-Nazi Telegram channel in March that posted a graphic that said, if you have a bug, give a hug, spread the flu to every Jew, Holocaust. And this is just one of the many, many examples that very clearly frames Jews as responsible for the pandemic. It identifies Indian communities, Jewish communities, minority communities, as well as law enforcement agencies as legitimate targets of attack. They talk about techniques like the using of spray bottles filled with bodily fluids from infected people to spray surfaces, to spread the virus by coughing and touching surfaces that are touched by people in shops and public transport. And these are discussions that we see being put into practice by those who are associated with this ideology. And we see this on posts on Telegram, on Facebook, 4chan, various neo-Nazi chat rooms. But what is also interesting is that there have also been a lot of groups who have changed because of COVID-19. So we spoke about the Taliban and Shabab as very deliberately attacking healthcare facilities and healthcare workers. And both of these groups have responded quite differently to the challenge of COVID. Taliban, for example, has offered to assist humanitarian organizations helping victims of COVID. It is cooperating with local authorities in some parts of the country. It even said that it would declare a temporary ceasefire in those areas of Afghanistan most heavily impacted by the disease. It's been distributing images of its own members in protective gear, treating people in health centers that it controls, enforcing social distancing, distributing masks, soap, gloves, speaking with community leaders about social distancing and other precautions. So it's very, very interesting. The same way we see Somalia's Shabab, which has a very long track record of targeting humanitarian aid groups and workers and opposing help from international aid agencies. They actually, in June of this year, announced their own coronavirus prevention and treatment committee. And then very, very quickly, they established a COVID-19 center around 400 kilometers south of the capital, Mogadishu. And it also started talking about how Shabab had its own vehicles to transport patients to the treatment center. So it was very, very different from the previous position that Shabab had. So what is the point of all this? And this is where I'm going to wrap this up, given that I've already gone over my assigned period of time. The point is that when we are talking about healthcare and terrorism, we have to understand that there are very many different responses by terrorist organizations to the healthcare issue. We need to understand this. We need to understand this difference. We know that terrorists respond to health on ideological grounds, but as well as strategic grounds. And when we look at the data, when we look at the research and terrorism studies, we always see that strategy trumps ideology. So the policy implication of this is to find ways to make it strategically important for terrorist groups to contribute to health, not only in any one particular setting, but across the various conflict zones that we can think of. And this is where I will end. Thank you very much for your time and patience. And I'm open to any questions if we have time.
Thank you so much for your time, Doctor. We're going to hold the questions for now, and then we're going to our next speaker, and then we're going to come back with questions, okay? Thank you so much. For those who are watching us and wants to leave questions on the chat, okay, feel free to do it. And now I'm going to present you guys the next speaker. Is Dr. Renee Critchlow. She is the Director of Advocacy and Policy for the University of Minnesota, Department of Family Medicine, and she is the co-founder of a youth health career mentorship program in North Minneapolis called DELAD. Welcome, Dr. Renee. You have the word now. Thank you so much for your time.
Thank you. I'm just going to try to share screen, I think.
Okay.
Can you hear me?
Yes, we can.
1 second. All right. First of all, I want to thank the Global Health International Congress for inviting me. I really appreciate it. I am very big into advocacy and policy is my big one. I was asked to speak on, oops, this is not going the right direction. Hold on. I was asked by Dr. Michaela McCuddy to speak, and part of the challenge was it's going to be on conflict policy and international cooperation. As mentioned, my position is primarily does with health policy. I'm a full spectrum family physician, and I teach and practice at the University of Minnesota. And one of the big things that I am responsible for is health policy development in our department. We teach medical students, residents, and the general public practicing physicians regarding health policy. Just a quick input about what family medicine is for some folks who've not heard of this particular specialty. So in the United States, if you go to medical school for your first 4 years, and then you go to a residency training program in order to get trained for your specialty. The specialty I've been trained in that I also teach now is family medicine. We go from prenatal care all the way through hospice and everything in between. And the community that we serve at our residency program is North Minneapolis. It's a low wealth community, primarily underserved African-American and refugee and immigrant population in Minneapolis, Minnesota, in the United States. And one of the reasons family physicians have really been embracing the idea of working with advocacy and policy, and I will talk about what both of those mean to me, is because we've come to realize things like the social determinants of health. The social determinants of health are a big bunch of words that actually just mean your surroundings in your life impact the way your health and the health of your family is. In fact, one of the things that's very challenging is that a lot of the data on healthcare outcomes say that over 80% of healthcare outcomes depend on the social determinants of health, and only about 20% of healthcare outcomes are influenced by what we actually do as physicians in our exam room. And so, as I said, for family medicine, we take care of the entire family throughout the entire spectrum of life. And if we're actually trying to keep our patients and the populations we serve as healthy as possible, we have to find ways to address these social determinants of health. The pie chart is always sort of a part of academia, and not many people like it that much. There are some folks, when they're talking to policymakers, and one of the big issues that we have in the States is everything is developed by the elected, every policy is developed by the elected policymakers. And a lot of them don't necessarily have the experience or the expertise on the issues that they are making regulations or laws about. And so they listen to somebody. There's an advocate from someone talking to those people as the policymakers make their decisions. And we're hoping that it would be stakeholders, people who live in the communities, people whose lives are impacted most by these policies. Very often it's not. Very often it's the people who would make the most money on how these decisions would be made. So if your economic, your social status, where your living conditions, personal individual choices, they all have great bearing on your health, but there's so little of that a patient actually has control over. A lot of that is dictated by the community you live in. And so instead of saying social determinants of health, one of the things that we've started teaching is health begins where you live, learn, work, and play. And that allows people to really grasp what those social determinants of health mean. The neighborhood you live in has a great impact on your healthcare. The school you're learning in, or if you're in school, the places you work, or if you're allowed to work. The fact that, where you play, very important. The fact that if you have green space in your neighborhood, it actually mitigates a lot of poor health behaviors and increases your health outcomes for more positive. So learning all this, that basically 80% of healthcare outcomes depends on stuff that feels out of my control as a physician. One of the things that we started teaching and doing is understanding that when we advocate for the health of our patients, we advocate for positive change in our communities. And our voices as physicians are heard more than the folks that we take care of. The people in our neighborhood are amazing, resilient. They deal with a lot of challenges. And as a whole, they have been burdened by a lot of society's choices. And one of the things that we do is teach the ways to help tell the stories to the policymakers and make them understand that the people we care for are very important stakeholders, and the decisions that they make have great bearing on the health of the communities we serve. So there's a story, one of my learners, one of my interns taught me a long time ago. He was talking about how there's a guy walking along the beach. He's walking along the beach and he sees there's tens of thousands of starfish just everywhere. And there's washed up on the beach and they're starting to dry out. And he sees another person picking up one of the starfish at a time and tossing it back into the ocean. He would pick up one of the starfish at a time and then they would toss it back in the ocean. And the guy goes up to this person, he says, "Hey, there's tens of thousands of starfish out here dying and desiccating, and you're just tossing them back one at a time. What does that mean? Does that mean anything? And are you really making a difference?" And the guy picks up a starfish and he tosses it back in the ocean. And he said, "It made a difference to that person. It made a difference to that starfish." And that's sort of what we're trying to teach, the idea of it's not just one or the other. It's both and. It's both caring at the bedside for your patient, whether it's in the hospital or in the clinic, but also, using your voice as a physician and your privilege as a physician to voice and amplify the voices of your patients and their stories and their neighborhoods and the community we serve. Whether I'm at the bedside teaching and taking care of patients or at the state legislature, we want to find ways that we can help the communities we serve. And advocacy basically comes from, I believe, the Latin of ad meaning to and vocere meaning voice, directing your voice. And one of the things that we do is we try to train our physicians to direct their voice to support their patients at policy levels. They advocate so that the things where when they live, learn, work, and play, when policy decisions are being made about that, they'll be a part of it. At one point, there was supposed to be a light rail that was built through the neighborhood we serve. And when they were looking to decide how they were going to do it, one of the big things they did was they did community meetings. They went out to the different communities and they would talk to people and said, if we brought this light rail transportation through, what would it mean for you? So when we saw that happening, we made a point of making sure that our physicians were at those meetings. We made sure that our patients were at those meetings and we were there to support them. When they had write-in letter campaigns about, what does this mean? Please comment. We made sure that we taught our residents, physicians, and our faculty how to write letters in support of saying, this is about health in all policies. If our neighborhood is connected by fast mass transit to the downtown area, it's going to provide more jobs for our patients. And more better jobs for our patients improves their health. So we definitely got involved with that. And when you're talking to people, you're like, why are doctors caring about whether there's a light rail in a neighborhood? And it's like, it's because health does begin where we live, learn, work, and play. And providing that kind of transportation for our patients would have changed lives. So other things, more concrete. Insulin in our country, in the United States, is ridiculous. The price that's paid by patients and insurance companies is insane. It gets to the point where we've had patients who've died or almost died as a result of trying to ration their insulin so that they are able to both pay their rent and take their medications. It's not an isolated incident. It happens all over in our state in Minnesota. there were some politicians who got together with some stakeholder groups, some patients, physicians, and they said, let's make a difference. Let's make a change. We need to find a way to make insulin more affordable for the populations that we serve. They put together a bill that would go through our state legislature. And if it became a law, it would do things like provide access to emergency insulin for any diabetic who needed it. It would provide decreased low-cost insulin opportunities for any patient, whether they were insured or uninsured, which is a very big issue in our country. So as they started putting this through the state legislature, one of the things they looked for was support and allyship from those of us in the healthcare community. And as physicians, it was our duty, I believe, to be there testifying before the state legislature, telling the stories of our patients, talking about the fact that, you know, a father tells a story about how his son, type 1 diabetic, missing 2 days of insulin because they couldn't afford it, and how he ended up in the intensive care unit. And then we get to talk and we say, yes, we're taking care of these people in the hospital, in the intensive care unit. And the fact is that the only thing that got them there was the money not getting to insulin. There was a family that wanted to take care of their son. There was a willing participant as a patient, and money was the only thing getting in the way. And that money was basically profit. It's not about the amount of money that was needed for the insulin. So we got there. We took up our resident physicians. They testified. I testified. We were speaking truth to power. And the thing is, a lot of folks in those powerful positions, they want to make the right decisions, but they're only listening to the people that are speaking to them. And if we weren't there speaking to them, the only people that would have been speaking to them was big pharma, the pharmaceutical companies that had a very good set of reasons why they had to have thousands of dollars a month for insulin, whereas in other countries it would be less than $40. So we were there to express the voices, amplify the voices of our patients, to express the needs of our community. And if we weren't there, the only people that they would be listening to would be the pharmaceutical companies. A very important part of being a physician is standing between your patient and power and speaking so that power can hear what your patient needs. So health begins where you live, learn, work, and play. Something we're very committed to, something we're basically teaching advocacy and policy in the same manner that we're teaching obstetrics. Everyone leaves our program with the ability to deliver a baby, and some of them leave with the ability to go out anywhere in the world and get the training to deliver any kind of baby. And they do extra work. And we do that with our advocacy and policy training. Every single one of our physicians that leave our department will have the ability to engage with decision makers, engage with stakeholders, and partner with communities, which we think is very critical. Because health does begin where you live, learn, work, and play. If it's going to have that great an impact on our patients, we need to participate in it. So, as I said, policy is really about bringing the voice to those in power, and also understanding that our privilege does come with a lot of responsibility as a physician. If I just think that the best way I can care for my patient is just to stay in that exam room and do my best, and yet I have patients who I can tell whether or not they have a home or not just by looking at their lab numbers. Because when they have a home, their blood pressure is well controlled. Their insulin is in a refrigerator and their daily sugars are so much better. Same person when they're unhoused or homeless. When I take care of them, all of their numbers are bad. Their life is challenging. They're living in a chaotic place in a chaotic way. When you're living in a shelter or your car, it's not as easy to take good care of your multiple chronic illnesses. The fact that if we just can house the unhoused in our country would decrease our healthcare costs immensely. No one's going to do those kinds of things unless physicians are actually participating in giving the advice and advocacy around those kinds of policies. The policymakers and the politicians, many of them know that they do not understand what they are making rules about. They listen to the people that speak to them. Right now, the people that are speaking to them, especially in our country, are all about power and profit. and physicians need to be there to speak truth to power. It should be about patients and communities, and we need to be the voice for them. So some of you may have heard about Minneapolis for the first time just this year. We unfortunately have had a great deal of civil unrest due to the fact that our police department, Minneapolis Police Department, has over the last few years murdered a number of Black and brown people who have not been, basically they've been killed in the streets. And George Floyd this spring really brought it all to a head. And it was one of those things where we were in the middle of a pandemic, and then George Floyd is murdered on videotape. An 8-minute, 46-second videotape of a man being killed in the street. And as I said, this was not a unique incident in Minneapolis. Over the last 5 years, there's been at least 3 extrajudicial killings in the street of Black and brown men. And it got to the point where people just were not going to take it anymore. They weren't going to be satisfied with it. Big challenge was this is literally at the beginning of the pandemic in our country. And it was a very big choice for us as physicians who take care of people who are threatened by the current state of structural racism in our country. We take care of these people. We care for their community. We are these people. And we had to make a choice. Is this a time when we're going to make sure our voice is heard and the voices of our patients are heard? And as so often it happens, we were led by our youth, our learners, our medical students, our resident physicians, our interns. They all were vigorously demanding that we find ways to address structural racism. And even if that meant being in the street or being at the state capitol during a pandemic, we were going to do the best we could appropriately public health wise, but we weren't going to let one of the biggest public health threats in this country, United States, is structural racism. So we had a novel coronavirus and a hundreds of year old wound, which is structural racism in America, combining at the same time. We felt very, very prepared to work with community organizations, to work with policymakers, to work with all the stakeholders who were involved on many different levels, because we started years ago understanding that it was important for us to voice what needs to be heard, to express the voice of our patients and the communities we serve. I will repeatedly say it because that is what it's about. So one of the things about teaching and about policy is we have to understand that the realms of power define the systems of health. Where you work, the clinics or hospitals that you work in aren't separated from all the power games that are going on in this world. And they can go on many different levels. We talk a lot today about local level. We do work on state, national, and international, global level. Clearly understanding that there's lots of different realms and they all overlap, especially in health. Health in all policies is one of the mottos that we like to stick by. When you talk about the different realms of power, you talk about geopolitics, interaction between land and power. Noopolitics, as they call it, the interaction between information and power, which is very large right now. Realpolitik, it professes to be a realistic approach to addressing policies. And when you look at all of these are systems and ideas and approaches, but none of them is sufficient to change the challenges that we face. When we look at where we are, many different health systems, many different approaches to what is the good, what is value, what is health, what is wellness. So many things that we have in every aspect, from the local all the way up to the international, there's so many different systems. There's not one size fits all. I can't be in Minneapolis, Minnesota, USA, and tell you how you can address the different health policy issues in your country. But one of the things that I do know and that we are trying to bring in is the idea that power is currently in the hands of people who don't quite understand. I'm going to give them not necessarily I'm not going to say they're intentionally making bad choices, but it's clearly that many are making bad choices. And one of the things that we have to do, I believe, as physicians, is make a different realm, make a choice about what is important. And what is universal is the idea of compassion. And I think for health policy and advocacy, we need what's called a symphonia politic. Yeah, we just made up the word, but we're going to reinforce it. It's from the Greek, meaning compassion, or making a harmonious sound together. The idea that we, as a profession, as healthcare providers, as physicians, we have the compassion, and we want to help wake that compassion within the people in power who are making the decisional choices. So if those are the reaction between land and power, knowledge and power, Symphonia Politique would be the interaction between compassion and power. And that is where our voice is needed as physicians. As physicians, we need to be augmenting that space between compassion and power, and that's where advocacy belongs. So if you're thinking about, am I advocating for someone? What am I doing, and is it right? Are you bringing compassion into a space where there is power? And are you voicing the needs of those who can't speak for themselves? Are you using your privilege to advocate change for the better? That's what we're looking for. That's what we're trying to teach. And when we can be the advocate between compassion and power, we can actually make a difference. We can make a change. It's not easy, but we have to commit to being in that space. So there are a lot of different voices. We have so many different challenges, but I also believe we have a lot of opportunities. As physicians, amplifying the voices of the patients and the communities we serve, we have an appropriate place in shaping health systems and healthcare. And it is our duty, it is our responsibility, and it is our honor to be there. So, thank you. They said 20 minutes, so you got 20 minutes.
Thank you so much once again, Dr. Renee. It was an honor to listen to you.
Thank you.
So now going back to Dr. Hashimi with one question. Dr. Hashimi, we would like to know if is there a way to ensure the security of the professionals on the field of conflict areas, and if so, how it is done?
Thank you. That is a very, very difficult question that you've asked me, because obviously there are protocols in place, and it's safe to say that international organizations like the United Nations, MSF, and various others that work in conflict zones obviously know what they're doing. They are used to working in a conflict situation. However, one of the biggest problems with a conflict zone is that protocols are often not met. And this goes not only for non-state actors, but also for state actors. Regularly, healthcare is put on the backseat for political gain and strategic purpose. And that essentially means that the way forward is to find mechanisms of not only recording what are the problems that are emerging in a conflict situation, but also finding ways to implement penalties if certain criteria and protocols are not being met, either by healthcare professionals, either by state organizations or by non-state actors.
Okay, thank you so much for your time, Dr. Hashimi. It was an honor to have you here in our Congress.
Thank you so much.
And now we have some questions for Dr. Renee. Okay, Andressa, can you continue?
Okay. I have one question for you. Here in Brazil, the population usually participates actively in municipal meetings, like to suggest some demands of health policies and for the neighborhood. This is very, very common here. What do you think about this type of representation? The population leave like new ideas to the government. Do you think this is a good thing, or this is something that not working? And have something like this in your country too?
Yeah, so thank you. That's a really good question. And so, yes, we have very often for a lot of decision-making processes, there's what's called public meetings beforehand. And one of the things that's challenging about that is that issues about who can participate. A lot of my patients, they don't have transportation. Some of them are unhoused. A lot of them work 3 jobs and need to take care of their children at the same time. So sometimes those voices aren't in that room. And I think as a physician, or just, as a good human being, whenever you're in a situation where power is being exchanged or discussed, first thing you need to think about is who's not in this room that needs to be here. And as a physician, those are the people I believe we need to advocate for the most. It's like, I'm here to express the voice of the voiceless. And yes, we've had lots of places and public meetings and things like that, and it's beautiful. But there's a chance, a very strong chance, that the people that it's going to affect the most are not necessarily in that room. So maybe that's when it's a very important time for us to be the voice in that room.
Thank you so much.
I have one question for Dr. Renee too. I'm trying to create a parallel between USA and Brazil, because we also have a huge problem with structural racism in here. We also have Black people being murdered every day in our streets. And it's a problem that's going on and on and on for years, for decades. So what I'm trying to create, to ask you, is those people that you said that need to be listened, how can we approach them? How can we make them feel listened? How can we make them feel safe in a way that they can talk what they're feeling, their needs, and try to end this awful culture of racism in both countries?
So that's a really great question. So what I would say is this, is one of the things that's most important in my mind is to pull back and to try to get a realistic view of what's going on. There's so many people who are like, they don't understand. When I say structural racism, that is the key. The structures that we have built reinforce what's going on right now. One of the things that's really critical to point out to people is it's not working for anyone, even those people who are in power. I mean, think about the rich people in your country. How much money do they spend protecting themselves and their families? Everyone's living in fear because of the way we've set up our structures. Just reinforces a place where there are very poor people and there are very rich people. And we like to use race to maintain those structures. I don't know about your country, but in our country, a great deal of the socioeconomic disparities come from decisions that were made a generation ago about how they weren't going to let Black people buy houses because they wouldn't give them FHA mortgages, how the Black returning GIs from World War II were not given GI Bill loans and so didn't go to college. We are living with the sequela, the follow-up of all the decisions that were made 60 years ago. We had this thing called redlining in our country, where if you were on a map and it was in the red, within the red zone, you couldn't buy a mortgage. And every one of those places, when you look at them now, they're poverty-ridden. They're some of the lowest wealth communities there are. And you think about the fact that they removed the possibility for multi-generational wealth because these people were put in places where they couldn't invest in their neighborhood. And now we're looking at the poverty that's come as a result of that. So one of the things that I always point out to people, I said, this country is not working for anybody. Structural racism has established, we have police forces that are stronger than many militaries. We spend money incarcerating people as opposed to educating people. It's like it's putting money in the wrong place. And this is where I always pointed out. I said, it's not even working for the white people in this country. In our country in 2018, over 18,000 white men shot themselves in the head and died. They committed suicide. This structure isn't working for anybody. And we need to find the ways that we can remove the barriers between us, provide equity, not equality. Equity is about putting resources where they can make the biggest difference. And one of my good friends always talks about centering at the margins. If you can make the people at the most extreme margin of your society, if you can make them educated, healthy, functioning, quality of life, if you can do that to the margins, everyone else does better. Too often we've been centering at the center. We need to center at the margins. And when we do that, everything gets better for everybody. So that's what I say. It's a structural issue. It's not working for anybody. And if we put equity as our priority, it will improve it for everybody. Put the resources where they will do the greatest good, and that will actually impact all of us for the better.
Thank you, Dr. Renee. Does anyone have any more questions? Because I think I do want to talk another topic that you said, Dr. Renee. When we talk about Brazil and United States, mainly here in Brazil, the vision that United States gives to us is of the perfect country. We were raised like that. But as we grown up and as we study, we see that it's not the truth. So do you think that it's harder for countries that see themselves as like perfect countries or first world countries, and it's harder for countries like Brazil, development countries, to reach a point of equity?
Yeah, so I think you hit on a couple of really good points there. Is it Edson? Yeah. So I think you hit on a couple of very good points. Number one, you guys, you're a whole lot younger than me. I got to tell you, when I was growing up, USA was even more the shining city on the hill that is perfection. And yeah, it's like, ooh, we could travel anywhere in the world and people are like, hey, USA, yay. You know, it's just, you know, my parents came to this country and, you know, seeking education and life. And, you know, it's not that we don't have amazing things. It's just that we've decided that some people are allowed to benefit from it and others are kept away from it. And this is one of the big things that I hold dearly to, is that it's not about the fact of America, it's about the promise of America. And that's what I believe in, is that every day we wake up and try to make the promise true. The promise is liberty and justice for all. That's the promise. And that's what we're going to hold them to. We're going to keep holding them to it until we actually have it. And so I think in the US, there's a lot of people who are blind to the idea that it's not working. And that's okay. The facts are in the facts. But everyone believes in that promise, and we're going to use that as sort of our, you know, our ruler, our marker of, are we doing what we said we were going to do? In places that don't necessarily have the romantic dream of the perfect country, because we have that romantic dream of the perfect country, we do, and it's been reinforced throughout. Even when Martin Luther King, he's like, I have a dream someday that, you know, judged by not by the color of our skin, but by the content of our character. Americans love to put that like visionary dream. But the thing is, we also have a lot of people that are willing to fight and move forward towards it and work together. So what I would say, where you are, what is the myth of your country? What is the mythos of your country? What are the stories that are told at holidays about what this country is? And are you holding yourselves to the level of, yeah, this is what we could be? And this is the thing. If you don't have that kind of mythos in place, maybe it's time you said, we can do this. Maybe it's just time you said, as human beings, we deserve to be good to each other. We deserve to be caring, compassionate, kind people. We deserve an infrastructure for our society that provides an opportunity for that to be the easiest choice. It should be the easiest choice that we're compassionate, loving beings. Right now, it's this dog eat dog, slice up the pie. There's no pie. There's choices. We make the choices about how we want to spend our resources. And so if you don't have that mythos of liberty and justice for all, and someday everyone will be judged by the content of your character, not the color of the skin, then you find a way to make that. You find a way to make it about the true values of human beings. And maybe you'll be the one that has the great speech that they'll be quoting for the next 50 years.
Thank you so much, Dr. Rene.
Yeah. And thank you guys for inviting me. I appreciate it.
We were honored to have you here.
Thanks.
Okay, thank you. I think we arrived at the final. So it's the end of our Congress today. It was a pleasure to have Dr. Rene here with us, really. I love your talk. So.
Thank you.
Yeah, I also would like to say thank you for the invitation. It was a truly honor to be here with such amazing professionals. Thank you, Andressa. Thank you, Luisa.
Okay, so I think we have today. I hope everybody come in the next weekend, because we have 2 more days of our Congress, and I hope everybody can come to the next weekend. We are waiting for you. And now it's good night from Brazil for everyone, and into the next weekend. So I think this is the final. Thank you, everybody.